Unmute yourself.
Unmute yourself and say yes.
Yes, sir. Yes, sir.
Yes, sir.
Okay. SAG Trivandrum, please unmute yourself and say yes.
Yes, sir.
Okay. Prenai Medcity,
Yes, sir.
GMC.
The group is as ABCD, EF. Okay.
Yeah. Gokulam Medical College,
Yes, sir.
Anandapuri Hospital,
Yes, sir.
Trishur Medical College.
Yes, sir. So, GMCT,
So,
KMCT Calicut is A, SAT Trivandrum is B, Prenai Medicity is C, GMC Medical College is D, Anandapuri is E, and Trishur Medical College is F. Start with A.
Okay, so just I'll introduce myself, and I am Dr. PMC Nair, and this is Dr. PC Alexander. I am dedicating the quiz to his name.
thank you so much.
He was my great friend, philosopher, and guide, and a great personality. Such a philanthropic person, devoting his whole life to helping others, and his main interest was on street children also. He is such an immortal figure. So we dedicate the quiz to his memory. So, okay, we'll go to the quiz. The rules are each answer 10 marks. So the Dr. George will be the scorer. Somebody should be the scorer also there.
George is the scorer.
Okay, 20 seconds for each answer. No carryover because of the Zoom problems. And we'll have total of 6 rounds. And as usual, the judge's decision will be final. So no fighting in between. Let us enjoy a day of learning together like yesterday, though there are a lot of problems. So these are the type of rounds. So we start with the team A, round 1, knowledge round. So team A ready?
Yes, sir.
Okay, so the question is to team A. Who introduced kangaroo mother care for the first time and where?
Sir, Edgar Ray and Martin in the year 1981 in Colombia.
In Bogota,
Colombia.
Okay, good. Here you said is
1981.
Okay, it can be given. 1978 they planned it. 81 it came as a paper. So full 10 marks to them. 10 marks. Okay. So we go to team B. Are you ready?
Yes, sir. Yes, sir.
Identify this equipment, indication for use, and beyond what gestation is it recommended? Very simple questions. Day-to-day life.
Sir, laryngeal mask airway.
Correct. Indication.
Indication to secure the airway when it is a difficult intubation. If we are not able to intubate, we can keep an LMA just to secure the airway.
One definite situation, specific situation. And beyond what gestation?
Sir, 32 weeks.
No, wrong. So the first part, again, they get 5 marks. The laryngeal mask airway for difficult airway, mainly in the main things, Pierre Robin, cleft palate, maxillofacial defects, injuries. So 34 weeks and more of gestation, more than 2 kg. That is as per the NRB 2050. So 5 marks for them. Second, next we go to team C. Team C ready? What is exit procedure? And mention 2 situations where it is done.
Utero intrapartum treatment. 2 situations.
Okay, I didn't hear.
Ex utero intrapartum treatment therapy.
Okay.
Situations in CDH and tracheoesophageal fistula for laser fulguration of PUV, cystoscopic fulguration.
Pardon?
PUV cystoscopic fulguration
in fetal.
And we can also do balloon valvuloplasty in heart disease extra.
No, where it is mainly done? Where is it mainly done?
In tracheoesophageal fistula.
Tracheoesophageal fistula due to congenital?
Diaphragmatic hernia. Balloon valvuloplasty for heart diseases.
Okay. I think we can give the marks, 10 marks. So main thing what you have to say is this CAVOS. CAVOS is the congenital high airway obstruction, severe airway compression obstruction. Then you keep the baby out, do some corrective surgery and procedure, and then go ahead with the delivery. Okay, I think we can give them 10 marks. Of course, team D, which factor in breast milk inhibits attachment of enteropathogen E. coli to intestinal cells and the renal solid load of human breast milk?
Lactoferrin.
Very good. 5 marks. What is the renal solid load?
Of turn hormone.
20 seconds.
Time over.
Time.
So 5 marks for them. Lactoferrin is the right answer, and the renal solid load of breast milk is between 93 to 97. Cow's milk is very high, 308 milliosmoles per liter. Okay, now we go to team E. What is the target temperature for therapeutic hypothermia and should be initiated within dash hours after birth?
32 to 34. Initiated within 6 hours after birth.
Yeah, correct. 10 marks. 10 marks for them. Then team F. What is Quintero's classification staging for which disease and what is its definite treatment?
Twin transfusion syndrome.
Yeah, very good. And definitive treatment? I think we didn't get the question correct. Any particular definitive treatment for this sort of problem?
Time up.
Okay, so the first answer is correct. That is 5 marks. Twin transfusion syndrome. This Quintero's classification 5 stages: bladder visible, bladder not seen, the donor twin, Doppler, all based on the donor twin actually. Fetal height drops. 4th and 5th will be one twin or both demise. Laser coagulation is the treatment to prevent the complications. Okay, so we want to tell the total, or we'll come to that after that. Now we'll go to round 2, which is values round. So also very simple questions. So be relaxed, enjoy. Okay, team A, neonatal hypocalcemia is defined as ionized calcium less than. What is the calcium requirement for growing preterm? And what is the bedside diagnostic test for hypocalcemia?
So neonatal hypocalcemia is defined as ionized calcium less than 1.1.
As what? 1.1 what?
Millimole per deciliter. And
is it for deciliter?
Millimole per liter, sir.
Okay. Calcium requirement?
40 to 80
mg per kg per day.
mg per kg per day.
40 to
80.
Okay. And bedside diagnostic test?
Tetany, presence of tetany.
Shostak sign.
Shostak sign or presence of tetany.
Not in newborn. Okay, I think time is also, they get 10 marks. No, 7.5 marks, sorry. 7.5. The answer is, first answer is correct. Either 4 milligram per deciliter or less than 1 millimole per liter. And those, if you say total, and it will come to about 200 milligram per kg per day. How much did they say, George? It's a very low value, they said, isn't it? So actually, and ECG is QTC interval, Bassett's formula, that is corrected QT interval more than 450 to 500 milliseconds. So they get actually, this is the total requirement of calcium for a preterm. So they get only 5 marks. Hello, George? Scorer?
5 marks. 5 marks.
5 marks.
Okay. Then what is extended perinatal mortality rate, team B? And what is the current perinatal mortality rate in India? You can say which year. 20 seconds.
Hello, sir. Perinatal mortality rate.
20 weeks, 20 weeks of gestation to 7 days after birth, the whole divided by 1,000 live births. Current perinatal 23%. 23%
per live birth.
per 1,000.
Okay. Second part is correct. So the first part is, it should be, this is only situation where the denominator is not live births, but just stillbirths and total number of births only. So that is important. More than 22 weeks to first 7 days of life by total number of births into 1,000. So how much, the other answer is correct. PMR in India is 23 per 1,000, but it's still coming down. One study it has shown around 20. Anyway, Kerala it is very low. So how much score of 5 marks?
5
marks.
Okay. Then team C, as per AAP, sound levels in NICU should not exceed dash decibels. What is profound hearing loss?
Profound should not exceed 65 decibels.
How much?
65 decibels.
65.
Right.
Okay.
Profound hearing losses. 20, 25, 25, more than 80.
So you get 5 marks. The 45 dB is the accepted inside the NICU, 45 decibels, and the profound hearing loss is, what is that, more than 80 to 90 dB. Okay, so they get 5 marks. So we go to the team D. Team D ready, 0 score in New Ballard score for gestation age assessment corresponds to dash weeks, and 2 items in this score with a negative score of -2. You are doing it every day, so it should be easy for you.
24 weeks of gestation.
Good, wonderful, good job. What are the 2 items?
Graces.
Not soul crease. Anything else?
Scarf sign.
No. George?
Complete point.
Time up.
Okay, they get 5 marks. First answer is correct, 24 weeks. And this one is on the plantar surface, the distance heel to toe less than 40 millimeters get a score of -2, and the fusing of eyelids -2. Less than 26 weeks, baby's eyes are fused like nammude poochakuttiyalude pole. Okay, so you go to the next team. So 5 marks only. Team E, what is the normal serum osmolarity and what is the breast milk?
Normal serum osmolarity 290 milliosmol per kg, and
Okay.
that of osmolarity of breast milk 260 milliosmol per kg.
260. Can say a range. Can you say a range?
240 to 280.
Okay, I think we can give almost both of them almost similar together. So serum osmolarity is around 275 to 295 milliosmoles per liter, and the breast milk is 290 to 300, whereas formulas are higher osmolarity. So they can be given marks, 10 marks, because they range they set almost okay, almost 10 marks. So we'll go to team F. What is the spectral irradiance delivered by A, conventional phototherapy, B, intensive phototherapy?
അത് 425 to 475 ആണ്. അത് റേഡിയൻസ് അല്ലോ. 425 to 475 നാനോമീറ്റർ. 60 ലക്സ്.
Time up.
No, what was the last one you said? 60?
Lex.
Which one? Conventional or intensive?
Intensive.
So, no marks. 8 to 10 is usually said as microwatts per centimeter square per nanometer. And for intensive, it is more than 30 microwatts per centimeter square per nanometers. So no marks. Now we go to the next round.
Do we say the score?
Yeah, it may be better. You can.
So
Yeah.
team A is 15, scored 50 points. Team B has 10 points. Team C has 20 points. 15 points, sorry. Team C. Team D has 10 points. Team E has a maximum of 20 points. And Team F has got 5 points.
We'll go to round 3. Can you go to?
Yeah, please.
So this is a clinical case scenario round. So you will all score full marks. So this is a 36-hour-old team A. We can listen.
Yes, sir.
36-hour-old team male baby presenting in NICU in shock. All pulses weak. Capillary refill time is 4 seconds. Heart rate 180. Cardiomegaly. No murmur. And SpO2 76%. What is the probable diagnosis and which drug can be life-saving? And the dose.
Yes.
Baby presenting in shock.
Sir, coactation of aorta. Supravalvular aortic stenosis.
No, you said one diagnosis strongly. Possible. Possible
Supravalvular
diagnosis. Coarctation of aorta is correct.
Okay. Sir, drug
Time.
PGE1.
PGE1 correct. And what is the dose?
10 mg.
Time.
Okay, so they get how much? 7.5. 7.5 marks. The answer is what correct. It's a critical congenital heart disease. But shock means the systemic circulation is dependent upon ductus. So hypoplastic left heart, coarctation of aorta, interrupted aortic arch, prostaglandin E1. Starting dose is very small dose. That is why calculating is always difficult when you are in a hurry. So better to look up somewhere that dose. Okay, so we'll go to the team B. Team B. This is a term baby, 3.1 kg, admitted with respiratory distress, and this was X-ray finding. So very clear what is the diagnosis and describe the X-ray also.
It shows us. Yes, it shows us no man's sign of heart.
Yeah, good.
PAPVC.
Otherwise, what do you call that? Other than snowman?
8 figure of 8.
Okay, good. And X-ray and diagnosis?
PAPVC.
Okay, so they get full mark. What type of TAPVC? There are different infracardiac, supracardiac, and like that, isn't it?
Supracardiac.
Okay, so they get full marks. Figure of 8 or snowman appearance. The paratracheal shadow on the right side is the prominent superior vena cava, and left is the vertical vein. TAPVC, TAPY, total anomalous pulmonary venous return, type 1, supracardiac type. Okay, so full marks. So to the next team, team C. This is a 3-kilo baby who presented with poor feeding and poor activity, characteristic order of urine, and sepsis screen negative, urine ketones 3+, ammonia is 300. By itself, we can say the diagnosis. I'll give you one more clue. What is this MRI? What is the MRI finding? What is the diagnosis? MRI is diagnostic.
Time.
Helmodin spat sign, multisystem atrophy.
No. Time out.
Time.
Okay, so we'll come. I thought it was very easy because in Kim's baby was diagnosed just looking at the MRI. So MRI shows a diffusion weighted T1 image. That is why you are seeing the ventricle spaces as dark, isn't it? Hyperintensity or increase. You see that reflection in the peri-rolandic white matter, basal ganglia, and it's a classical. And you also urine smell, maple syrup, urine disease. Maple syrup is a very tasty syrup available in US. The trees. Maple syrup, urine disease. Okay, so they get no marks. George. Okay, team D. Team D, are you ready? What is this picture? The baby had undergone therapeutic hypothermia for birth asphyxia. What are the lesions? What metabolic abnormality can be associated? If I attended one case of therapeutic hypothermia, it will be easy. Time?
Time.
No, I thought everybody would say this. This is what is called subcutaneous fat necrosis because of the cooling and the subcutaneous fat solidification, crystallization of the fat, of saturated fat, and the one complication can be associated with severe hypercalcemia. So no mark for this team, George. And then team E, what do we see here? And 4 causes for this, antenatal causes. That's a very common. Fine. One is ultrasound, the last one is MRI, T1 image.
Cystic lesions
Hmm.
in the periventricular area.
So what do you call that?
Uh,
You said that. Actually, what do you call that?
Periventricular.
Yes, what?
Leukomalacia.
Very good, my God. Cystic PBL. Okay. And 4 causes.
Congenital intrauterine infections.
Very good.
Hypoxia.
Okay. 2.
Then intraventricular hemorrhage later. Last stage.
That doesn't, that cause porencephalysis.
Porencephalysis. Then
so they get how many marks? 7.5. 7.5 marks. Is that George?
Yes, 7.5 marks.
Okay, we'll see the answer. Grade 3 cystic PBL. You can following antenatal like stroke, death of a co-twin, or the twin reverse arterial perfusion sequence, hypoxia, asphyxia, placental insufficiency, maternal smoking, chorioamnionitis, and viral infections. Okay, so we go to team F. What is the diagnosis and list the abnormalities?
Prune belly syndrome.
Very good. 5 marks.
Abnormalities. Pulmonary hypoplasia. Renal abnormalities. Cryptorchidism.
Okay.
Cryptorchidism.
Why the prune belly appearance? Why is the prune belly appearance?
Absence of rectal muscles.
Absence of abdominal muscles. Okay. One more thing. What you're seeing in the patient? There's a Joy, I think we can give them full marks. Okay, full marks. Prune belly syndrome. The classical pictures are the genital anomalies. It can be anything like cryptorchidism, ectopia vesica. This baby has a suprapubic catheter drainage of the urine. and deficient abdominal wall is then giving the appearance of the prune belly. Have you seen prune? The same appearance of prune belly syndrome. Okay, and this is a suprapubic catheter drainage of urine that is put there. Okay.
How many marks?
So let's discuss the marks by the end of the round. Team A has 22.5 marks. Team B has 20 marks. Team C has 15. Team D has 10 marks. Team E has a maximum so far is 27.5. And Team F is 15.
Okay, so now we go to the next round. It's an acronym round. So some people who are very interested in acronyms, it will be very easy. We had breastfeeding week celebrations recently, so more questions are centered around it. Okay, so remember, so Team A, we are not going backwards and forwards because again it may cause confusion. So going forward from Team A only. Okay, Team A, question 1 is, what does WABA stand for? What was the theme for 2020?
World Alliance for Breastfeeding Action.
World
Alliance for Breastfeeding Action.
Good.
And theme for 2020 is sustainable breastfeeding for a healthy planet.
Okay, good. So 10 marks. World Alliance for Breastfeeding Action, support breastfeeding for a healthier planet. So Team B, expand NIDCAP, NIDCAP. Where and who started it? DNB exams you get as a short note question also.
Neonatal and infant.
Neonatal? No, louder. Where and who started it? George, can you hear? I can't hear clearly.
Not audible as time is up.
One more chance for them. One more chance. What did he say?
Okay, 5 more seconds.
Neonatal and infant development.
And you're coming to that. Development and?
Development.
No, sorry. So we'll,
Time's up.
okay, the answer is newborn, NIDCAP, newborn individualized developmental care and assessment program. It's a very important program started in 1997 and it's become NIDCAP Federation International Program. It was started by Heidi Lisi of Harvard University. It's a comprehensive program looking at the tiny baby as well as the family, not putting the guilt on the family, helping the family very well, giving them all guidance, interactions, and developmental supportive care. You'll get a short note question, NIDCAP, newborn individualized developmental care and assessment program. Okay. So Team C, what does IBFAN stand for? IBFAN stand for, and where was the first BFHI started in India and when? That is easy. Team C.
Breastfeeding and infant breastfeeding.
Where was the first BFHI started in India? Where was it started in India? Where and when? Time out. I thought this was. Where?
Chhattisgarh.
No, in your own place only. Anyway, Cochin, 1992-93 March, around that time. International Baby Food Action Network. It's a very important network. It's controlling that infant food marketing and substitutes issues. Okay, we go to the next team. Team D. What does ILCA stand for? When and where was the first BFHA conceived in the world?
International Lactation Consultant Association Action.
And when and where was the first BFHA conceived? That you should know. BFHA comes as a short note question always, isn't it? George, time?
Time up.
So they get 5 marks. International Lactation Consultant Association. And the other one is Ankara. Ankara is the capital of Turkey. In 1991, International Pediatric Association mooted this program. Okay, next team. That is team E. What is BPNI and first state in the world to be BFHA certified?
Breastfeeding Promotion Network of India, and the first state is Kerala.
Very good. Good. So 10 marks. Kerala 2002. And team F, what is JSY and who is the key person of the program? Team F.
Janani Suraksha Yojana.
Very good. 5 marks. Who is the key person? Most important person in this program?
Prime Minister.
Number 5 marks. Answer is very simple. Not the prime. The lowest person there is the ASHA worker, poor ASHA worker. She has been, that is, ASHA is accredited social health activist. She is being given very important place in this because she is going there and collecting all the details, giving the money, promoting institution delivery, etc. Okay, so with that, I think that is out. One bonus question. This is very interesting question. Anybody who knows can answer. Unmute and answer. Hamlet.
Identify yourself
Human
and answer.
alpha lactalbumin leads against tumor cells.
Oh, wonderful. Which team is that?
SAT.
Very good. So we'll keep some extra mark for you.
What is the mark you allotted for that?
No mark for that, no? No mark.
No, we will keep it in the end. Anyway, what they said is true. This very rare one. Actually, I haven't heard about it at all. Human alpha-lactalbumin made lethal to tumor cells. This is actually a whey protein which is can do something like apoptosis, tested in the skin papillomas and bladder cancer. Very good. So one extra feather for SAT. So round 5, we come to visual round. That also we quickly go. No passing on. Okay, team A. What is this picture and what is the principle of the test? Hemoglobin of 9 grams on day 1. What is this diagnostic test? What are you seeing there?
So immunofluorescence microscopy.
Wrong answer. What is the principle?
So it is a KB test.
KB test,
Kleber test. And,
yeah, correct.
And fetal-maternal hemorrhage.
Okay, so you get full mark. Anybody prompted you? Hopefully no.
No.
Okay, so full marks. Kleber test for fetal-maternal hemorrhage. The main principle is the fetal hemoglobin is resistant to acid and alkali. So acid resistance is the test is done. So what you see as it's beautiful to see under the microscope is done in many other medical colleges. The red cells appear, the fetal cells appear red, while the maternal cells appear like ghost cells. Okay, so we go to team B. Or what is? Can you see that it's being covered by? What does CFM stand for? And identify the picture and diagnosis.
This is AEG showing a discontinuous. This is a discontinuous one. CFM is continuous fetal continuous fetal monitoring. Continuous fetal monitoring.
Now, what does CFM stand for? It is written there also. What is CFM?
Oh, sorry. CFM is microvolt. So this is cerebral. This is the cerebral function. It assists the cerebral function. Function monitor.
Okay, so you get that, and the second answer. So they get 5 marks. Actually, it's just showing what You're seeing? Can you see the, do you know how it is read?
Sir.
Sir, this should be the lower margin should be above 5 and the upper level should be above 10.
Okay,
That is
correct.
continuous, and this looks like discontinuous because the lower one appears below 5. So
Okay. So what is it? What is it? What is diagnostic of?
it is diagnostic of asphyxia or cerebral
Okay,
reduced
so they
cerebral
get
function.
full marks. A lot of difficulty, but full marks. Cerebral function monitoring. This is a normal. The lower limit we should not go beyond 5. Here it is going beyond 5 microvolts, and the upper is more than 10. But here there is no sleep wake pattern like this. Okay, so 10 marks. So to the next team, team C, team C, George, team C.
Team C.
Okay. See this MRI brain of a 2-year-old baby child with neonatal seizures. Describe the MRI abnormality and your probable diagnosis.
White matter degeneration. White matter leukodystrophy, X-linked. Adrenoleukodystrophy.
Sorry.
The racing car appearance of no, it's not racing car. It's a white matter disease, sir. Hello.
Dr. George, time?
Time up.
Okay, just see that picture. That's a bilateral symmetrical atrophy of the brain and hyperintensity of the parieto-occipital and medial occipital regions. You are seeing that on the lower this region. So that is suggestive. This is actually suggestive of neonatal seizures also. So most probably, probable diagnosis only hypoglycemic brain injury. Okay, so no marks. We go to the team D. What is the image on the right side? Right side. See the image on the right side. What is the characteristic finding? This is a normal lab. Pardon? Any diagnosis?
Hyaline membrane, bronchopulmonary dysplasia.
No, you have to say correctly, full. Bronchopulmonary dysplasia, part of it is correct. What are the two types of bronchopulmonary dysplasia that you know of now, BPD?
Fibrous tissue.
How much more? So we can give them how much? What is the characteristic finding between the two? Anyway, having thought of BPD, we give 5 marks. The answer is new BPD because we can see the lack of septation and developmental arrest, isn't it? On the right side, you see no septation at all. The older one is the one that is old BPD, which is inflammation and fibrosis. Okay, to next team, 5 marks only. Team E, what is this image? What is the red arrow showing? What should be done to improve? What is this whole image? How do you call that? Team E.
Loop.
What loop? Correct only. Proceed.
Volume loop.
What else?
Red
What else? And what is the arrow showing?
Showing.
What is the arrow showing? Because if you know
Maximum
that,
tidal volume.
what is that?
Tidal volume.
No. And what should be done to improve the condition?
Time.
Time out. Time out. Okay, so they get 2.5 marks. They identify the picture. That is a pressure volume loop in pulmonary graphics. It's a classical beaking. It's called beaking or breaking point. Maximum extension, over distension of the lung. So the main thing you have to do is bring down the pressures. Pulmonary PEEP or even PEEP you can decrease. Mainly PEEP. Okay, so team F, Doppler in a 22-week fetus. What does it show? Diagnosis and management. Fast. Hmm?
Reversal of end-diastolic form.
No. So what is this Doppler showing? George, time noikkonne. George, time.
Five more seconds. 5 more seconds.
Middle cerebral artery.
Yeah, middle cerebral artery. Doppler. And what does it show? What is it showing?
In fetal anemia.
Okay. And what is the management? What is the management treatment of fetal?
Time out.
In the transfusion, in the utero transfusion.
Okay, good. So they get 10 marks. I don't know how they, with a lot of difficulty got it, but they said finally correct. Middle cerebral artery flow velocity. The Doppler showing a narrow peak systolic velocity, which is suggestive of severe anemia, high drops, and intrauterine transfusions they want. So they get full marks. Good. Now we come to rapid fire. This is going to be only 1 minute, 6 questions, and 5 marks for each correct answer. So you can get a lot of marks here. Okay, shall we start with team A? George, are you ready?
Yes, sir.
Please identify the team and tell the answer.
No, it's A, B, C, D.
A, B, C, D.
No, it is going to 6 questions. 1, 2, 3, 4, like that.
Okay, sure.
You immediately say the answer. We'll discuss it at the end. Otherwise, you won't have time. Only 1 minute, within 1 minute. So if you have any doubt, don't stay on there. Pass on.
Sir, each team will get 5 questions, 6 questions, or
Each team.
Okay.
So we can come back to it later.
Can we pass and come back?
You can come back to it later if you. But within 1 minute. After 1 minute, no. So time.
No passing, and 1 minute it gets over.
Yeah. So shall we start with team A? Ready?
Yes, sir.
Yes, sir.
Okay. What is the best clinical indicator of successful intubation and ventilation as per NRP?
Chest rise.
Wrong answer. What are postbiotics?
They are pass. Next question, sir.
What is the intracellular storage form of surfactant?
Lecithin.
No, wrong answer. Lower position of UAC in X-ray.
Below L3.
Okay, L3, L4. What is extra precaution to be taken while giving lipid infusion?
Thrombophlebitis.
No.
Or sepsis.
No, very important while giving lipid infusion. Extra precaution.
Precipitation of the lipid.
What is that?
Precipitation. Next question, sir.
No. Next question. What is the app test is done to?
1 minute over.
App test.
Swallowing of the blood.
Time up.
This we can give. Anyway, started. The app test is done to?
Fecal transplantation.
Fecal transplantation. Postbiotic.
No. App test, I thought it is very easy. Anyway, so they
app
get only.
App test we have told, sir. Swallowing of the maternal blood to rule out.
Okay. So 10 marks. Two correct answers. George?
Yes, 10 marks for team A.
Okay, so we'll quickly see the answers. The best indicator of successful intubation success inflation is increase in the heart rate. And exhale carbon dioxide detection, we don't have that filter paper, that litmus paper. Postbiotics are products of microbial fermentation, short chain fatty acids, acetate, propionate, butyrate, etc. Storage form is lamellar bodies. You said acetate. Low USA correct. Protect from light because of photo-oxidation peroxide formation. That is why you see it is covered with a aluminum foil or special colored tubes. And maternal is good. Okay, so go to team B. What is breast crawl? Team B, ready?
Breast crawl, just after a delivery, the baby is put on the mother's abdomen and the baby will crawl up to the breast and start sucking.
Okay, correct answer. Incidence of CP in PVL grade 3, periventricular leukomalacia grade 3, incidence of CP. You can say a range.
50%.
50?
Sir, 50%.
50%.
No. High position for UAC. Umbilical artery catheter. High position.
L1.
No. What is permissive hypercarbia?
permissive hypercarbia, we can give carbon dioxide can increase to a rate such that the pH does not fall below 7 point.
Keeping the pH at 7.3, we can allow the carbon dioxide
dioxide
PCO2 to rise to 50 to above 50 to 60.
Correct answer. Specific test for diagnosing hemorrhagic disease of newborn.
Time up. 1 minute. 1 minute. Up.
PIVKA levels. PIVKA levels.
Then sixth question.
Time up.
Newborn presenting with cardiac, respiratory distress, and scaphoid abdomen. This CDH, and incidence of CP is, sir, 45%.
No.
45 to
So
50.
last two they get 5 and 6 and 4. 4, 5, 6 answers correct. So how many marks? 50 now.
15.
Okay, so quickly see the answers. Quickly, newborns correct. You said incidence. One is also there. So 5 more marks. George, 5 more marks. CP incidence 67%. High UAC between T6 and T9. PCO2 is said correctly. PVK 2. Proteins induced in vitamin K absence 2. CDH you said. Event duration diaphragm also we can say that differential. So they are getting how many? 4 answers correct.
20 marks. 20 marks.
Okay. Then team C, 2 probiotics in breast milk.
Lactoferrin and bifidobacterium.
Lactoferrin
and bifidobacter.
Okay. Biochemical indicator for protein insufficiency.
Next question.
Pass. What is the importance of number 17?
Prematurity. World prematurity day.
Okay, good. Newborn with micrognathia, cleft palate, glossoptosis.
Peary-Robinson.
Very good. Correct answer. Physics principle behind variable flow CPAP.
Physics principle. Bernoulli principle. Bernoulli slow.
No. What is DASI?
Development assessment score 2.
Okay, so 3 answers correct. 3 answers correct.
5 is Laplace. 5 is Laplace. Laplace is low.
Time over.
Time up.
Okay, what did you say? 5?
Laplace is low.
No. So 3 answers correct. So we'll quickly see probiotics is the lactobacillus and bifidobacterium. Protein insufficient in this is blood urea nitrogen and serum prealbumin. Both are decreased. That will give an indirect biochemical evidence. World Prematurity Day, Pierre Robin said, Coanda effect are the fluidic flip mechanism in that thing. And the other one is, you should know, comes as a short note question, developmental assessment scale for Indian infants. You cannot say this. So 3 answers correct, right?
3 answers, 15 marks.
Okay. So we go to team D, Espan Nava, NAVA.
Pass, sir. Next question, sir.
What is the role of surfactant apoprotein D?
Pass.
What is rheotrauma in ventilation-induced lung injury?
Pass, sir.
Go to the next question. Sore nipples are mainly due to?
Improper positioning.
Correct answer. Protein responsive cow's milk allergy?
Whey protein.
Wrong. Detection of oxygen saturation by spectrophotometry is based on what law?
Sir, answer for 5th question, lactalbumin. Lactoglobulin.
What lactoglobulin?
Alpha. Beta.
Okay, they can give 2.5 marks for that. So only 2 answers correct, right? 7.5. Now you should know there is a new ventilation mechanism, neurally adjusted ventilatory assist, alveolar host defense is a surfactant protein D, injury to lungs due to rheotrauma, inappropriate airflow. If you keep the ventilator flow high, you can get that. Then this you said. alpha S1 and alpha S2 caseins and beta lactoglobulin. Beta lactoglobulin is not present in breast milk. Okay. And the other one is Beer-Lambert law. Beer-Lambert law is responsible for pulse oximetry. Okay, now we come to team E. What is the principle of working of Massimo pulse oximeter?
Pass.
Okay, most effective antenatal intervention reduces incidence of IVH.
Antenatal steroids.
Okay, correct answer. Optimal timing for genetic amniocentesis.
10 to 14 weeks.
Wrong. Gold standard for diagnosis of Hirschsprung disease.
Biopsy, rectal biopsy.
Okay, correct answer. Biochemical marker for HSPD and preterm.
Biochemical marker. Urine output.
No, biochemical. How does heparin excess alter the ABG?
Acidosis.
Others, please mute the phone. Acidosis, anything else? So only one. Others, please unmute. So the total how much getting? 7.5. അല്ലേ ഒരു ആൻസറും ഒന്നര ആൻസറേ കറക്റ്റ് ഉള്ളൂ. 7.5. So the answers quickly. Signal extraction technology. Antenatal corticosteroids, you said. Between 15 and 20 weeks of pregnancy. Rectal suction biopsy. Rectal suction biopsy, you said?
Yes, sir.
Two answers correct. So not 7.5. 10 plus this one is increased serum levels of beta natriuretic peptide and ischemia modified albumin. That is the latest one, IMA. And excess heparin cause a dramatic decrease in CO2 because air means CO2 less, PaO2 very high. So that means 10 plus 2.5. 12.5.
12.5.
Okay. Now we're going to team up. This is the last series. So we should be able to finish DDST2 or Denver 2. Which sector items are almost double compared to DDST1?
Pass. Next question, sir.
Birth length of a baby doubles by?
Length double by 2 years. Length. Pass.
Yes, PaO2 in descending aorta fetus is?
Positive. 30 to 40 PO2.
30 to 40, no. Teratogenic effect of methimazole.
Cutis aplasia. Cutis aplasia.
Oh, okay. So that will give mark. Then gold standard for gestational age assessment.
First trimester US.
Very good. Correct answer. Whole blood glucose levels measured by reagent strips are dash than plasma levels.
Whole blood glucose will be more than plasma. 10 to 20. 10% more.
Think about it once more.
Birth length doubles by
time up
4 years.
Okay, so 4 years is correct answer.
Decreases by
2 correct. Gold standard. So 3 correct answers.
The 10% less than 10% decrease. Whole blood glucose level.
Okay. So 4 correct answers. 4.
20.
1, 2, 3, 4. Time out. You won't get time. So the language item is the one that is double. 4 years you said correctly. 15 to 20 millimeters of mercury is the PaO2. Aplasia cutis, choanal isoatresia, VSD, minor facial anomalies. First trimester ultrasound you said 3. 15% lower than plasma value. That's why if you get a glucose strip value of 20 or something, you can be at least happy that the value in the blood will be, in the plasma will be slightly higher. Okay, so that is all. We finish with that, isn't it?
Yeah. Can we read out the scores at this point?
Yeah, the winner. Yeah, you can say the winner in a second. Okay. No time. Okay.
Yeah. Team A has got 52.5 points. Team B, SAD Trivandrum, has 50 points. Team C, Renai Medicity, has 30 points. Team D, Gokulam Medical College, is 27.5 points. Team E, Anandapuri, has 52.5 points, and Team F, Thrissur Medical College, has 50 points.
So who is coming first?
No,
we need a tie.
We have a tie between KMCT, Calicut, and Anandapuri.
Anandapuri is always coming for tie. So shall we go to that question?
And the second place also, we have SAT and Thrissur Medical College.
Okay.
Thank you. Thank you.
So we'll go to the first tie. Right?
So we need all the four.
How is the tiebreaker?
Sir, how is the tiebreaker now?
Tiebreaker will show the picture and then who are answers first.
It is 11:30.
Okay, sir.
Or shall I ask separate questions to each person? That will be difficult. That will not be fair.
11:30. 11:30.
No, we'll have. Can we have separate questions to 4 teams?
Oh, other prayers Anangati. We'll show one picture, and whoever says, whoever just puts the hand up and says first will be taken.
So which all teams are having the tiebreaker first?
Tiebreaker George, tiebreaker Araka Tamilana.
Can I tiebreaker is between KMCT Calicut and Anandapuri. That is one.
So we'll do that. We'll do that first. KCT
Yeah. Can we have one question for that tiebreaker? One question.
Sir,
one question for the tiebreaker. So who are answers first between KCT and Anandapuri?
Yeah,
others, please unmute. Mute. Okay. Only KCT and Anandapuri open, and we'll have the first question. Okay.
Yes, sir.
Tally, have the first question. Are you ready?
Yes, sir.
Ready?
Ready.
Okay. So what is this pneumonia with abdominal distension? What is this X-ray show? Look clearly in the abdomen and mention 2 associated conditions. Answer first. Okay, Anandapuri, then start.
Dilated bowel loops, and in between gas shadow is not seen, indicating some intestinal obstruction.
Sir, annular pancreas.
No, so both the answers are wrong. What should you do? Can the other
calcification of the kidney, calcification of the right side of renal calcification.
Yeah, calcification is correct. Calcification is correct.
Renal calcification.
No.
Renal calcification.
No.
Meconium. Lactobacillus.
No.
Pancreatic calcification.
No. No, Anandapuri came nearer to that. Before that, you said something.
Meconium.
Meconium plug.
Meconium ileus.
Meconium plug.
And what are you seeing there?
Cystic fibrosis.
Yeah, correct. Okay. So who said that? Both of you said, this is meconium calcification. Meconium peritonitis calcification.
No, who is the winner?
Nobody.
Okay.
Who said cystic fibrosis?
KMCT, sir.
But meconium also, she said.
I think we'll have one more question. Tiebreaker again. I think we'll have one more question because again a tiebreaker between 2.
Okay.
One more question for them.
Okay. So what is this? First, who are put the hands first? First.
Autosomal dominant inheritance.
Yeah, correct. So they are getting the mass. And name 3 conditions.
Sir, neurofibromatosis.
Correct.
Sir, primary microcephalus, autosomal dominant type. Sir, then.
Okay, what is the degree of inheritance?
Sir, so 25%. 50%.
Okay, good. Okay, answer is correct. So it is autosomal dominant inheritance. Polycystic kidney, tuberous sclerosis, hereditary spherocytes, etc. So they KCT gets the tie.
Who wins that?
George.
Yeah.
KMCT.
KMCT wins.
And second, first.
Okay, then
Second
which is the other?
Second is
Annapuri.
Can I say something? KMCT, can I say something? KMCT wins first. The second prize is Anandapuri.
Yeah, that's it.
Okay. Now again, there's a tie break between SAT and college.
SAT and?
The question of Hamlet.
They said Hamlet. Actually, that's mark കൊടുക്കാം. It's a very difficult question, alle.
Okay,
so they get the credit.
So SAT gets the third prize because of the answer.
Bonus question.
Bonus answer.
Oh, okay.
Okay.
So the winner is KMCT Calicut. Second is Anandapuri Hospital. SAT Trivandrum.
No, actually, so don't have any ill feelings. Everybody did very well. Actually, it's a very vast area. So like preparing for the quiz. The person who is making the quiz also is a very difficult thing because you want to try to put in everything possible, isn't it? Anyway, so I think you enjoyed the program, learned something. That is more important. All of you will be getting the certificate also. And the best thing is we kept up to the time because 10:30 is the conference starting. Hello.
Yeah.
Thank you,
can you announce the winner of the free paper also?
Okay. The second person, I don't know the name.
Yeah, that is from Renai Medicity. Dr. Lakshmi.
Yeah, her presentation slide, both were same issues, rare case entities, but the second was slightly more, presentation was slightly better and more clear.
Okay, thank you so much. Shall we go on to the inauguration ceremony? Can you stop sharing?
Yeah, thank you very much for not having any hassles.
Thank you so much.
Thank you very much.
So again, thinking of the memory of PC Alexander. If you come across him, he was such a wonderful person. I don't think anybody had come across like that. And
thank you.
Thank you
so much. Okay, start the inauguration. So we're going to start the inauguration now.
A very good morning to one and all present here today. It gives us immense pleasure to welcome you all for taking the time out to join us for the inaugural ceremony of the 5th Perinatal Monsoon CME 2020, organized by Aster City Center of Excellence Child and Adolescent Health and Women's Health in association with IIP Cochin Branch and Cochin Obstetric and Gynecology Society. The Monsoon CME is an integral part of Aster City's academic program and is conducted with great vigor every year. To ensure continuity of our efforts, this year the program has been taken onto a virtual platform and we are happy to welcome this august audience. On that note, we move on to the inaugural ceremony. Dr. Jose Paul, our organizing chairman of Monsoon CME 2020, will deliver the welcome address.
Good morning, everyone, and thank you for all being participating in this CME. In fact, we had a elaborate plan for a large and good interesting topics finally. As you all know, we had to come to this short webinar.
The Galaxy M31, please mute yourself.
Okay. It's a great pleasure to welcome all of you for this webinar. I know, as I said, we had to cut it short for a short one. And I will make my speech with short because of the lack of time. I welcome Dr. Narayan, the IAP State President, to this meeting. And then Dr. Harish Pillai, our head CEO, Aster India and Aster BM Healthcare. And Dr. M.K.C. Nair, all of you know him, and he is our former Vice Chancellor of Health Services, Kerala University. And all the dignitaries who are present here who have taken time to be part of this discussion. And I wish all of you have a good time and we learn a few things from here. We have some eminent speakers, including from abroad. So hopefully we have a good time. Welcome to all of you.
Devo.
Thank you, Doctor. Request everyone to please be on mute.
I'm hearing, but I'm not seeing.
Kindly mute your microphone, please. Light symbolizes knowledge, purity, and is the dispeller of darkness.
No, you may press like this. So
Dr.
the
Narayan
second
and
cycle is just closed.
IAP
So
State
like this.
President,
Then open.
please light the lamp to inaugurate the
Then
fifth
close
Monsoon
and
Monsoon
click
CME
that. And then I'm calling Puda Kalan Sagastana. Click on
Yeah,
this.
good morning to you all. Am I audible?
The one I called out earlier, Sheila.
Dr. M.K. Naya, former Vice Chancellor.
No, cut off mute. Then she called and told me your video.
Asked India. Dr. Fessy Lewis, Dr. Shirley Martin, Dr. Jason Ziunni, Dr. Jos Paul, the organizing chairman, Dr. George Jos, Dr. Tina Annie, my colleagues in IAP Kerala and IAP Cochin, and dear delegates in the Zoom. Actually, it is the 10th Monsoon CME organized by IAP Cochin. It started way back in 2011 when Dr. Varghese Cherian was the president of IAP Cochin and myself was the secretary. And afterwards, it has been a joint venture with the Aster team. And I have great pleasure in attending this one. And also, we have fond memories of Dr. P. Alexander. Some people leave for heavenly abode, leaving a vacuum which cannot be filled in the coming years. That is the story of Dr. P. Alexander, a true professional, a person committed to charity. And it is most appropriate that we are having this CME on a week when IAP, National IAP is observing the Chariot Day. It's a day meant for charity on the 26th of August. And I'm very happy to have Dr. M.K. Naya to deliver this oration, Dr. Alexander Memorial Oration. And with these few words, I'll formally inaugurate this conference with your permission by lighting the lamp here. Okay. I have the privilege of lighting on behalf of Dr. M.K. Naya, Dr. Harish Pillai, Dr. Shirley Martin, Dr. Fessy Lewis, and finally, my colleagues in IAP, Dr. Jason, Dr. George Paul, Dr. Pramod Vaidya, and all. Thank you all and wish you a happy learning. Thank you.
Thank you, sir. We value your wise words of advice. We have with us today the CEO for Aster Group of Hospitals India, Dr. Harish Pillai. He is one among the most influential leaders in the healthcare fraternity, being an expert in hospital administration, business strategy, joint ventures, etc., among many more. He has played a significant role in the development of the healthcare industry by setting new standards in quality and patient care across the country. I now invite you, sir, to address the delegates.
Thank you, Vinita. Distinguished colleagues, I had the pleasure to listen to the fascinating quiz. Dr. Nair, your questions were quite tough, and I must compliment all the participants and the teams which have won those awards. So it's a real feast on a Sunday morning to listen to the quiz. So thank you for that. Just have a few words. Some of you have recollected the memory of Dr. Alexander, who I fondly call as Alex. I have been associated with Alex right from 2013 when this institution, Aster Medcity, was being built. So originally the plan was to just have one pediatrician in the hospital. Believe me, because I built the hospital and I've recruited all the faculty. But Alex, in his own charming way, somehow convinced me to have this entire center of excellence for child and adolescent health. And from that one-man show, it became a real center of excellence. And more than an astute clinician, what I really remember Alex was his humanity, the kind of, the force for goodness which he always embodied. It took me some time because we have an institutional policy of having change in leadership every 2 years. So we had, after our first founder, Chief of Medical Services, Dr. Narayan Unni, I had to take some time to convince Alex to become the Chief of Medical Services. And I really remember the art of team building and consensus, which Alex had really personified. Many things, whether his acts of charity, which he never used to talk about. Sometimes he used to put all of his administrators in a spot of embarrassment because if he finds some patient who is not able to pay, be sure that he will pay it from his own pocket, which is actually not our institutional policy. We have funds available for charitable purpose, but that is what Alex is all about. His amazing sense of humanity. He lives on in all our hearts, and I'm really, of course, those of us who are blessed to have known him, we have fond memories. But it's the youngsters, the new generation of pediatricians and obstetricians. I think they have a lot to learn from a fine medical leader and a teacher like Alex. These have been testing times across the country thanks to COVID-19. Many frontline healthcare workers have either succumbed to this disease or have been severely, have been affected. Society, I would say, at least has recognized the critical role of healthcare workers in nation building. I really hope and pray that the politicians who have been destined to govern the country at this time, they consider health sector as a strategic necessity for the country. There is no point in saying that India would become a superpower if we do not invest in the basics of life, starting with healthcare. It's very important that at least a sum of 5% of GDP need to be allocated for healthcare, not just infrastructure, but human resources. Many efforts have been done by the National Medical Commission. These kind of CME programs, which is being conducted with the representative bodies of obstetricians and also pediatricians, go a long way in building the intellectual acumen of the new generation of doctors. So I really congratulate all the organizers. Dr. Nair, you are a legend in your own making, and the services which you have done for Kerala in particular, as the Vice Chancellor of the Health University, is well known to all of us. And we really thank all of you who have taken time to be available for mentorship of youngsters, and my best wishes to all of you. Thank you so much.
Thank you, Dr. Harish. We now move on to the felicitations. I now invite Dr. Pramod Warrior, IIP Kochi President, to share felicitations.
Thank you very much. Warm welcome. I thank the organizers for letting IIP Cochin branch be part of the Monsoon CME and offer the very best. Thank you all.
Thank you, sir, for your kind words. I now invite Dr. Balachandar, IIP State Secretary, to extend felicitations. Doctor, we're not able to hear you. I now invite Dr. Fessy Lewis, COG Secretary, to share felicitations. There seems to be a technical issue. I now invite Dr. Shirley Martin, Lead Consultant, Department of Women's Health, Aster Medcity, to share felicitations.
Good morning, Dr. Narayan, IAP Kerala State President, Dr. Pramod Warrier, IAP Kochi President, Dr. Balachandran, IAP State Secretary, and of course our dear CEO, Dr. Harish Pillai, and our dear Cox Secretary, Dr. Fessy Lewis, and my dear colleagues and friends. On this occasion of 5th Aster Perinatology Monsoon CME 2020 and 3rd PC Alexander Memorial Oration, I feel a sense of elation to join hands with our pediatrician and neonatology team. We remember Dr. PC Alexander, who was efficient, quiet, caring, and good administrator, who is still living in our hearts. And because of this oration, he will continue to be remembered by the future generation. The theme, Common Perinatal Challenges, holds great importance in the minds of the gynecologists and the pediatricians alike. Let the flame of knowledge burn bright and stay strong in our hearts in spite of this COVID times. Wishing all a wonderful CME, and thank you.
Dr. Balendran is on.
Thank you, Doctor. I now invite Dr. Balachandran, IAP State Secretary, to extend felicitations.
Thank you. Respected President Narayan Sir, Dr. Harish Pillai, the team of Aster Medcity, Dr. Jason Sioni, Dr. Jose Paul, my friend Pramod Warrier, the office bearers of Cox, and my seniors and friends from IAP Kerala. Today, I'm thankful to Aster Medcity for inviting me as the Secretary of IAP Kerala State to address the August audience of this 5th Aster Monsoon CME. Today, we have the theme of perinatology. We are lucky to have our teacher, MKC sir, to address give the oration of great human being, in the name of great human being, Dr. PC Alexander. I still remember him during the first Aster Monsoon CME 5 years back. He was organizing the event, a great human being. So I wish today's topic, perinatology, an advancing field in our medical field, will benefit our members who are attending this conference. So once again, I congratulate the Aster Medcity for organizing this event. Thank you. Jai Hind, Jai Hind. Thank you, sir.
Thank you, Doctor. I now request Dr. Tina Annie Joy, the Organizing Secretary, to propose the vote of thanks.
Yeah, start.
As we, I deem it a great honor to propose the vote of thanks to all those who have helped in making this seminar a resounding success. I would, in advance, express my profound gratitude to Dr. MKC Nair for his oration, which will happen. I would like to thank our distinguished speakers, Dr. Uma Ram, who took time out of her busy schedule on a Sunday to give us, which will be an enlightening talk. Dr. Christopher Harris, who will be joining us from London with his excellent talk. My sincere thanks to our esteemed moderators who will come today, Dr. Radhamani K, Dr. Jose Paul, Dr. Maya Devi Kuru, Dr. Shamima Anwar Sadat, Dr. VC Manoj, Dr. Rajshri S, who will give us inputs on the talks. I would also like to thank Dr. PMC Nair for the quiz program conduct and Dr. Zarina Khalid for the free paper session and Dr. Vishnu Mohan. I thank Dr. Jason Uni, Dr. Jose Paul, who will be chairing the oration, Dr. Shirley Martin and Dr. Jason for their guidance in conduct of the CME. I also thank the technical team No great webinar is possible without the technical backup by the IT team. I thank my co-organizing secretary, Dr. George Jose, for making my job a lot easier. I'm also thankful to our pharma sponsors. I would also like to end by thanking our postgraduates, fellows for their participation in the quiz and the free paper sessions, and all the delegate doctors who are attending this webinar on this beautiful Sunday, and thereby making it a grand success. I also give my thanks to Dr. Raj Warrior for joining me. Thank you.
Thank you all. We now move on to the main event. Over to Dr. George.
We'll start with a session on small, special, and looking for safety. That's the topic. And our esteemed speaker is Dr. Umar Ram. I invite our moderators, Dr. S. Mayadevi Kurup, Dr. Shamima Anwar Sadat, and Dr. Rajshri to moderate this session. Dr. Mayadevi Kurup is Senior Consultant at the Department of Obstetrics and Gynecology, Aster Medcity, Kochi. She is a Fellow of the Royal College of Obstetricians and Gynecologists and a Fellow representative of the RCOG AICC South Zone. She's a laparoscopic surgeon, a robotic surgeon, and the first gynecologist to perform robotic surgery in Kerala. She's a member of the Confidential Review of Maternal Deaths, Kerala, and has many publications to her credit. Her areas of interest are high-risk obstetrics, maternal medicine, critical care in obstetrics, and gynecology. Welcome, ma'am. Dr. Shamima Anwar Sadat, our other moderator, is a senior consultant at the Department of Obstetrics and Gynecology, Aster Medcity, Kochi. She is the lead for Aster Center for Fertility, Aster Medcity, Kochi. She is a laparoscopic and robotic surgeon and an IVF specialist. She is also a member representative of the RCOG AICC South Zone, again with many publications in peer-reviewed journals to her credit. Dr. Rajshri S., a neonatologist with 12 years of experience working at Aster Medcity, Kochi, is trained in neonatal intensive care from prestigious centers in India. She is also one of the national mentors for the National Quality Control Network of India and the Lakshya program of the Government of India. Her areas of special interest include low and extremely low birth weight babies, pulmonary physiology, and ventilation of neonates. I invite our moderators to the dais. Flight mode. Shall I start? Shall I start? Good morning, everybody. Dr. Fessy, may please give the felicitation.
Yes, sorry for that technical problem. I had to go for that. But on behalf of Cochin Gynec Society, I take this opportunity to, on all the members of Cochin Gynec Society, wishing all the best for this wonderful CME. I think in this webinar's era, there is a nice initiative of combining pediatrics and gynec societies to have this perinatology topics. I think we have prominent faculties in here, including my friend neonatologist Manoj VC, and all the senior gynecologists and other pediatric friends. Pediatric friends, I don't know most of them, except Narayan sir and Manoj. So I wishing, without wasting time, wishing all the best for this CME and webinar. Thank you.
Thank you so much, Dr. Fessy.
I invite Dr. Maya Devi to introduce the speaker.
It's my privilege to welcome Dr. Umar Ram, Director and Consultant Obstetrician Gynecologist, Sitapati Clinic and Hospital, Chennai. She is an excellent orator, a gynecologist and obstetrician, who is the chairperson of Southern Zone AICC RCUG, Part 3 MRCUG examiner, coordinator of Part 2 and 3 MRCUG course Chennai from 2003 onwards till 2018. She has contributed chapters, edited books, publications. She has got various accolades like the Young Gynecologist Award 2007 AOFOG, IDF Blue Ring Women Achiever Award Rotary International 2015. And her main areas of interest include fetal growth, multiple pregnancy and fetoscopy, GDM, health awareness in women. And her main hobbies include music, travel, and reading. I would like to welcome Dr. Umaram to this CME. Over to you, Uma.
Thank you very much, Maya, for your introduction. Thank you to you and Aster and Tina for the invitation to be a part of this CME. It's always a pleasure to be a part of a program in Kerala, and I quite miss the possible travels that would have brought me there inevitably at least once every few months. So it's lovely to see everyone virtually at least. So the topic that I've been asked to discuss is intrauterine growth restriction. And I thought we'll talk about these small and special babies who are looking for safety, both in delivery and in the subsequent neonatal care. Intrauterine growth restriction is an area which absolutely needs a good perinatal team and perinatology setup to actually optimize outcomes. And so let's begin by asking ourselves, why should we worry about smallness? We all know that any baby that is small, we are worried because there are in utero and postnatal risks. And there is good data to say that as the centiles drop in terms of weight, it is not just mortality, but morbidity also that increases with decreasing centiles. So if you look at the adverse outcomes, the odds of adverse outcomes worsen with the smaller the baby is. So when it's on the 3rd centile, you have more adverse outcomes than when it is on the 10th centile. So which is the number that we should use in order to call a baby growth restricted? Is it the 3rd, is it the 5th, or is it the 10th? Or are we just going to say that it is the failure of a fetus to achieve its own growth potential? That this failure to achieve its own growth potential is the recommendation that has been in vogue. But what we are interested in is the long-term outcome. While we may deliver a really tiny baby, the end point is not the delivery of this baby and handing over to the neonatologist, but to ensure that there is neurological intactness later on. The question that we need to ask ourselves is this baby small and well, or is it abnormally small? And the way to do that is to actually start by looking at the growth. But we realize that growth alone may not be enough because every small baby is not at increased risk of adverse perinatal outcome. So our management depends on our ability to distinguish that small baby which is at risk of adverse perinatal outcome, and therefore size alone is not enough. Now there are issues with fetal growth which are intrinsic in the way in which we identify it, because it's not a single point estimation. You definitely need at least 2 points on the graph for us to say how the baby is growing. While it is nice to say that it is failure of that fetus to achieve its own growth potential, we don't know what the growth potential of this baby is, and that is a challenge in identifying growth restriction. There is increasing evidence that the best growth centile for a baby for optimal outcomes is actually much higher than the 50th centile and maybe closer to the 80th or 90th centile in terms of minimum adverse outcome. So using just a 10 centile cutoff may be missing a large number of babies which are actually at risk. And so looking at growth velocity is also an area where there is a lot of interest. Now, this graph is important for us to understand because you can see that the open white dots are those dots of babies which have had stillbirths in the antenatal period, and the solid dots are those which have had stillbirths in the postnatal, in the intrapartum period. And you can see right away that when you look at babies which are under 32 weeks, more than 70% of babies have been below the 5th centile. But when you look at babies which are around 36 weeks upwards, they are not small, but have still succumbed or had stillbirths. And this is another point that we have to keep in mind. So this brings us to the fact that placental failure can happen early or can happen late. And when placental failure happens early, there is time for it to impact growth, and therefore we see it distinctly as a decrease in size. When placental failure happens late, the baby is already well grown, and therefore we don't have the luxury of time to show a drop in growth or a dip in weight in all such babies. So when there is early placental failure, the nutrition of the fetus is affected. There is a long latency to demise because these babies have the ability and the time to develop coping mechanisms, and there is time for us to identify that this baby's growth is dropping. But when placental failure happens late, it is more an issue of diffusion of oxygen through the placenta not being sufficient to for a fetus which has reached a reasonable size, and therefore in a sense it is the oxygen exchange or respiration that is affected. Therefore there is a short latency to demise, and as I said, there is no time for growth to visibly drop. So the consensus criteria for diagnosis of growth restriction is 32 weeks is the cutoff, and this was by a Delphi consensus. A growth restriction under 32 weeks is early onset, and this is how do you identify it? If you want to use a single criteria, it is AC or estimated fetal weight less than 3rd centile, or an umbilical artery showing absent end diastolic flow. If we use AC or estimated fetal weight of 10 centile, additionally, there should be a uterine artery PI which is over the 95th centile, or an umbilical artery PI which is over the 95th centile, for us to say that this baby is actually growth restricted. Late onset growth restriction, either you have an AC or estimated fetal weight which is crossing more than 2 quartiles on the growth centile chart, or 2 of the 3. Estimated fetal weight less than the 10th centile, estimated fetal weight or AC crossing more than 2 centiles, or a CPR which is less than 5th centile, or a uterine artery PI which is more than 95th centile. So clearly the consensus is that it is size alone is a criteria only when it is really, really small, but otherwise there needs to be some evidence of Doppler abnormality. So how do we monitor then these babies? And we look at it from as answers to 3 questions. Why should we monitor? What should we monitor? And how often should we monitor? So let's address the why first. The why is because there is no treatment for growth restriction. Once it develops, our only weapon in the obstetric armamentarium is delivery. And therefore, until we reach a point where we're happy to deliver this baby and hand over the ball literally to our neonatal colleagues, we need to monitor. So what are we balancing when we are monitoring? We are balancing prematurity versus the risk of stillbirth. And of course, as our NICUs have got better, and as our neonatal colleagues are far more confident of saying they can take care of the smaller babies at lower gestational age, yet our aim for delivery is beyond delivering a live fetus into intact survivability. That is why the impulse to deliver a growth restricted baby at the earliest sign of some umbilical artery abnormality needs to be reined in. Now, this was a slide courtesy Professor Ahmed Bashar, and I use it because it explains our dilemma or our approach to management beautifully. We know that until we come to 34 weeks, every week that we gain reduces the chance of major complications. We also know that after 36 weeks, every week onwards, the risk of stillbirth does increase. And therefore, 34 weeks is a watershed from the point of view of in the 35 to 36 week period is when the risk of major complications is low and the risk of stillbirth is lower. Now, if we take the other cut point, that is around 29 to 30 weeks, you find that under 30 weeks, you have a much higher chance of developmental delay in cerebral palsy. And after 30 weeks, the chance of developmental delay in cerebral palsy actually reduces. So you have two watersheds between which we have still to gain by pushing the gestational age at which we bring this baby out. And the tools that we have in order to do that are three. And the way we use them is based upon the fetal response to hypoxemia. So let's quickly go over how does a fetus which has hypoxemia respond. Now, when there is hypoxemia, initially there is chemoreceptor stimulation. This results in arterial redistribution within the fetus. And this causes in the fetus an increased flow to the brain, the adrenal, and the heart, because these are the most oxygen sensitive organs. A decreased flow to the kidney, the bowel, and the liver, which will manifest as oligohydramnios or decreased LICA. Decreased blood flow to the bowel is what is seen subsequently in the NICU as an increased risk of NEC, and the decreased blood flow to the liver is what actually translates into a lower abdominal circumference, resulting in reduced weight. Now, when there is worsening hypoxemia, you see a CNS dysfunction, which is what is reflected either as a change in the CTG showing reduced variability and deceleration, or a change which is noted when we do a biophysical profile, which is reduced movements, reduced tone, and reduced breathing movements. Now, even as we see this fetal response to hypoxia, we realize that CTG changes, and most of the changes that we document in the biophysical profile are not seen in the early stages of hypoxemia and seen only at the point where there is worsening hypoxemia resulting in CNS dysfunction. And that is the second point that we need to hold on to. So the CTG, while it is a tool which as obstetricians we are very comfortable using, yes, it reflects fetal hypoxemia, but only acutely at that point. Now, even though a normal CTG is reassuring and most of the time we are happy for this baby that nothing is likely to happen in the subsequent week, there is still in a growth restricted baby a 1.9 per 1,000 chance that a stillbirth can happen even if the CTG is reassuring. Now, what is more worrying for us is when the CTG is non-reassuring, its sensitivity to hypoxemia is only 50%. And therefore, it needs additional testing. And this is particularly complicated by the fact that a preterm baby's response to its catecholamine response on the heart is still immature. And therefore, the variability changes that we see on a CTG need to be interpreted very carefully. And therefore, the CTG in a preterm baby comes with the caveat that the obstetrician who is interpreting that CTG has the experience and the training to interpret it appropriately. Having said all of this, CTG is still not helpful to monitor progression because it tells us what is happening at that point only. Same about biophysical profile. But before we go there, increasingly when you look at evidence of literature for preterm growth restriction, they all talk only about computerized CTG, including Truffle and most of the guidelines. However, this computerized CTG and STV changes, while they are recommended and while they are the only forms which have been validated against invasive testing, they are not available except in a few select centers across the world. So while we may talk about it, what we are left with when we are monitoring our growth restricted babies is the standard CTG. And it is important then to understand that spontaneous repeated unprovoked CTGs are significant and they should be a trigger for delivery, not minor changes in the CTG. If the CTG changes in a standard CTG are just non-reassuring, use a second method, be it biophysical profile or Doppler, to validate your reason to deliver a preterm baby. The other point is, in a significant proportion of this computerized CTG abnormalities in the Truffle study could have been picked up with a conventional CTG because they were to do with decelerations. Now, moving on to biophysical profile, the same thing, it does not reflect progression, but it is a reflection, it reflects acidemia. So we move on therefore to Doppler, which is the most used technique in the monitoring of these babies, because the Doppler is able to pick up most of the changes that happen. It gives us placental information and fetal inflammation. The Dopplers that give us placental information are the uterine artery Doppler and the umbilical artery Doppler. The Dopplers which give us fetal inflammation are the MCA Doppler and the ductus venosus Doppler. Now, when we talk about placental insufficiency in growth restriction, we know that there is a cascade of phenomena that happen. It is a placental disease initiating by placental dysfunction. Of course, there are a group of factors such as infection, structural abnormalities, chromosomal abnormalities, which can cause very early onset growth restriction, which need to be excluded. Once we have placental disease, we know that this is reflected in the umbilical uterine artery Doppler as high resistance, umbilical artery Doppler as high resistance when about 30% of the placental function is affected. And for us to see absent or reversed end diastolic flow, 60 to 70% of placental function is to be affected. And at this point, the baby compensates by pushing its blood to the brain, which is what is reflected in the middle cerebral artery. And if hypoxia worsens, you get decompensated hypoxia, significant injury and death. And hypoxia to acidemia to stillbirth. This is what the Doppler tells us. So around the time that you start seeing absent end diastolic flow is when you often see that the baby is pushing its blood to the brain. As I said, this is the process of centralization. This is a positive adaptive response. This should not trigger delivery in an early onset IUGR because this is telling us that this baby is compensating well. So when then should we be worried in an early onset IUGR? When you start seeing reversed or absent reversed end diastolic flow, that could be a reason which correlates with venous Dopplers, and you're moving from a compensated hypoxia to decompensated hypoxia when you start seeing ductus changes. The ductus changes reflects or correlates very well to diastolic failure of the fetus. And finally, if we still don't deliver, you end up having systolic failure, which is seen as CTG decelerations and STV of less than 3 minutes, resulting, which is a pre-terminal event. So, okay, all this is fine, but I have to monitor this baby. How do I know whether what is the frequency with which I should monitor this baby? One of the first papers that addressed the progression of Doppler abnormalities was by Turan in 2008. And based upon the duration of time that it took for the baby or the fetus to move from one Doppler abnormality to the other, he classified it as mild, progressive, and severe. But however, you need to do that second Doppler to know which category is going to fall in. And therefore, we still have to plan when to do that first Doppler. Usually it will be a week based on the Barcelona criteria. And then depending on the stability and depending on the severity of the growth restriction and gestational age, we plan the frequency. Now we must keep in mind that maternal disease can make this progression unpredictable because the other impact of placental dysfunction is maternal hypertension and preeclampsia, which can tilt the balance very easily. So this is what we monitor and this is how often we monitor. Now the Barcelona criteria are very, very clear in the way in which they quantify the different stages of growth restriction, and they give us a guidance as to how frequently we should monitor. So I'll just quickly go through a case-based discussion to illustrate this point. This was a 26-year-old preemie who conceived spontaneously. She had a BMI of 21. Her FTS was screen negative. At 20 weeks, this is where her abdominal circumference was on the 5th centile, and the weight was also on the 5th centile. And the uterine artery showed high resistance, and the other Dopplers were normal. So she would then fit the criteria of a stage 1 growth restriction because you have 2 parameters that are abnormal. Now she was therefore, the use of graphs, I have put this here because you don't need anybody to give you any PI. The moment you see the dot there, you know very clearly what is going on. She was therefore followed up and rescanned at 28 weeks. And at 28 weeks, this is what we saw. You can see that the weight has fallen off the chart. Her umbilical artery PI is high, but her MCA PI and ductus venosus are normal. So she was then reviewed weekly. 2 weeks later, this is what we saw. So her middle cerebral artery showed increased diastolic flow, which we know is a positive adaptive response. Her umbilical artery showed absent diastolic flow and the ductus venosus is normal. Now, will this or should this trigger delivery? Not at 30 weeks, because the gestational age benefit is something that we have already discussed. So when the baby is less than 34 weeks, you need something more than umbilical artery as a point of intervention. So we continued, and you would be worried that you're seeing absent end diastolic flow. Now, many may want to steroid her at that point, because you don't know what is going to happen going forward. She was seen again in 2 days' time. And at this time, her umbilical artery just showed high resistance. There was still increased diastolic flow. Ductus was still normal. And 2 days later, there was intermittent absent and intermittent high resistance flow in the umbilical artery. Now, the points that I want to make here are 2 things. One, for a Doppler abnormality to be a trigger for delivery, it needs to be repeatedly demonstrated. And this is why, if you see the Barcelona criteria, they'll say that the Doppler has to be reviewed and repeatedly reproduced with 12-hour period. And this is to do with the technical difficulties with doing a Doppler. Secondly, as I said, the MCA is not a Doppler for decision making in early onset growth restriction. And for us to pick up intermittent absence, you need to have a reasonable run on the screen. If you just take a clip for 3 or 4 heartbeats, you're not going to see variation or intermittent. So you must have a long enough clip on the screen for us to be able to pick up. So this lady, we did do a CTG on her, and we kept monitoring her. We counseled her, and we kept seeing her. At 4 days later, similar picture. By now she had crossed 31 weeks, and we actually steroided her at this point. So what else should we need to consider at this stage if we are delivering this baby is steroids and magnesium sulfate. The timing of the steroid ideally should be as close to the point of delivery as possible. Don't steroid the moment you see the first Doppler abnormality, because you know that you may actually gain even 1-2 weeks in these babies if the growth restriction is not very severe. And we know that the longer, the closer the baby is to the time of steroid, within a week is when it has the optimal benefit. It must always be a single course, not repeated courses. And when the fetus has been given steroids, especially a growth restricted fetus, if there is absent or reversed end diastolic flow, there should be daily surveillance, because there is some data that the betamethasone may actually influence both the CTG variability and the Doppler changes. Now, magnesium sulfate, again, depends upon the gestational age. The timing is within 6 hours, well, at least 4 hours before delivery. And for neuroprotection, the dose is the standard dose, 4 grams loading, and then continue 1 gram per hour. And there is good data. And this Cochrane review was actually published almost 10 years ago, 2009. The number needed to treat to benefit 1 baby for neuroprotection is 63. So both are fairly strong interventions. But a word of caution about steroid use, because there is data, and this is this year's JAMA publication, that antenatal corticosteroid exposure resulted in a higher cumulative incidence of mental and behavioral disorders in children, which were followed for 5.8 years. So please restrain caution when you're giving steroids for later gestational ages. I know the RCOG guideline says up to 39 weeks for an elective CS. The way I would interpret that is to say, if you need to do an elective CS, don't do it till 39 weeks. But if the benefit on TTN is something that is just debatable, but we must remember that the benefit on RDS reduction starts to drop after 34 weeks. Certainly, we should avoid repeated doses. There are many units where simply because the woman has had IVF, every 2 weeks she keeps getting steroids. And that is a practice that we simply cannot condone and should actively change. So this patient was admitted at 31 weeks and 4 days because her blood pressure went up. She was given magnesium sulfate for neuroprotection. A cesarean section was done. A 942 gram baby with a pH of 7.2 was born. And this baby is now about 8 or 9 months old and doing well. So what is different if this baby starts becoming small later? Now, this lady actually had her 30th week scan elsewhere, was reported to be normal, came back to us at 36 weeks. When we scanned her at 36 weeks, the AC was below the 5th centile, as was the estimated fetal weight. And as I said, in these situations, because the baby could be affected by hypoxia before placental dysfunction exceeds that 30% or 40%, to reflect as an increased resistance in the Doppler. You may have a baby which is affected by hypoxia, even though your umbilical artery is not showing increased resistance. Also, these babies are used to getting good oxygen all along, and therefore they are less adapted to cope with hypoxia, and they decompensate faster. But the way they respond to hypoxia is the same. Every fetus responds to hypoxia by protecting its brain, and that is the beauty of nature, which is why you will see an increased diastolic flow in the MCA, even though the umbilical artery is not showing any significant increased resistance. And which is why they say that in late growth restriction, umbilical artery alone is not reliable. So you do what is called the cerebroplacental ratio, and look at the MCA PI versus the umbilical PI, because that ratio is more sensitive parameter for hypoxia than its individual components. Now, there is data to say that even if the biophysical profile is normal, when the CP ratio is altered, it is in that subgroup that 90% of stillbirths happen. But the word of caution here is usually at 36 weeks and later, the baby is cephalic, the head is inside the pelvis. The person who's scanning to get that middle cerebral artery ratio for you will apply a lot of pressure on the probe. That pressure on the probe itself can change the MCA PI. And therefore, there is a high variability, and it is very important that we reconfirm the CP ratio within 24 hours before we actually make the final decision for delivery. So, unlike early onset growth restriction, the delivery for late growth restriction is still a let's watch the space kind of thing. There is some guidance that comes from the Barcelona group, but it is not that strongly validated as the other guidance for early onset growth restriction. So if you have a fetus which is less than the 3rd centile, but Dopplers are normal, you review in 2 weeks. If you see a Doppler abnormality, you monitor twice a week, you increase the frequency because you need to monitor these babies faster, and you induce at 37 weeks. But if you see a CP ratio abnormality, you deliver. This could be a guidance that we use. Now, this is the 29-year-old lady, low risk except for her BMI. She had gained 13 kilos in pregnancy. Her 12th week scan, her FTS was low risk. She declined screening, but her scan corrected her due date. And this is what we saw at 20 weeks. It was a baby which was growing normally, but there was a uterine artery high PI. And that is so when we look to screen for risk factors that can increase the possibility of growth restriction, the first level of screening happens at the first trimester, when we see a mean artery PI, or if you do a formal preeclampsia screening. When we do a Doppler, uterine artery Doppler at the time of the target scan, if the mean uterine artery PI is high, then bring them back for a scan early at 28 weeks. If the growth is on the normal centiles and the uterine artery PI is completely normal, it's okay to follow them in the clinic and bring them back closer to 36 weeks, because that's when you're going to pick up late growth restriction. So at 28 weeks when we saw her, AC was on the 4th centile, FL was on the 2.4th centile, but Dopplers were normal. And this is how it looked, right? Dopplers are quite happy, but this baby is just a little bit dropped, but AC is gone below the 4th centile. And this is what we did. We called her back and did another Doppler. Doppler remained normal, but this baby's growth, as you can see, is dropped, it's just somewhere there, 3rd centile, and we had reached 35 weeks. Mother's blood pressure was normal. We steroided her at 35 weeks. Cervix was unfavorable. She had an elective section. Baby was 1.8 kgs. Did we do this right? Now, if you look at the guidance or indication to deliver, actually speaking, she did not quite meet the criteria even to call her growth restricted, because AC was not on the 3rd centile yet. There was no Doppler abnormality. But certainly this is a small baby we would worry about. And this is another area where there is a little bit of gray. We are a little uncomfortable about continuing, mainly because we know that, God forbid, at 36 weeks, there is a stillbirth. We will never forgive ourselves, because there needs to be a baby for the neonatologist to say, when a 1.5 kilo, 35 weeker, we know is going to do well in the NICU. So this was our dilemma when we decided. So is there any data about route of delivery and indication for delivery? If there are CTG decelerations, if there's an altered BPP, if there's a maternal indication, clearly if there's an umbilical artery abnormality, then we should deliver. The mode of delivery, the only data we have comes from the Digitat trial, where they looked at growth restricted babies at term, and they said induction versus expected management, there was no difference in outcomes in the NICU. There was no difference in cesarean section and instrumental delivery. But it will take a fairly brave obstetrician to induce an unfavorable cervix when you know that this baby is that tiny. But the weight of evidence suggests that actually we can, but we need to have a lot of monitoring in the labor room. So when really should we deliver these babies? After 26 weeks, we delay to gain viability. And we know outcomes are very poor, so we need to have an extensive counseling session with the couples. In most units, many units in India, except the high-end tertiary level units in the cities, you may have to do that even up to 28 weeks. And you would you counsel to wait with excellent monitoring to gain survival. Up to 30 weeks, we delay with monitoring in order to improve and reduce morbidity. Between 30 and 34 weeks, the reason for delaying is actually to give steroids once we start seeing a Doppler abnormality that, in this case, it would be a ductus abnormality or a reversed end-diastolic flow. After 34 weeks, when we delay for a fetal indication, there is going to be a higher neonatal morbidity. Once we cross 37 weeks in the context of a growth-restricted baby, there is no justification for delaying delivery. Now, this is from the last issue of guidance, most recent issue of guidance, which looks at the Doppler and CTG examination in a fetus. And it says pretty much the same thing, that up to 26 weeks, it's a personalized management. At 26, up till 28 weeks and 6 days, you deliver if there is a DV reversal, or if you have a computerized CTG STV of less than 2.6, up to 29 weeks to 31 plus 6, you deliver if there's a DV abnormality. STV may not be relevant to us. 32 to 34 weeks with an umbilical reverse or absent end-diastolic flow. 30 weeks and higher, again, umbilical or absent end-diastolic flow. 36 weeks and higher, if you have a CP ratio that is affected, or you have a birth centile weight that is less than 3rd centile. Any sign of cerebral redistribution beyond 38 weeks, we should deliver. And obviously, as I said, these are the absolute indications for delivery if there is any unprovoked deceleration altered by physical profile and any maternal indication. So the current issuer guidance gives a very comprehensive take on delivery. So it's very, very important for us to liaise with the neonatal team to bring them into the picture early enough to have combined detailed counseling so that the obstetric team and the neonatal team are not giving different messages. Sometimes we may be very reassuring to them, and then they go there and hear about deafness and neurological outcome, and also the cause, they may deter and wonder. So they have to be aware of all the complications. At the same time, we should give them confidence. We should quote our own literature, our own outcomes, because what is happening in a state-of-the-art unit somewhere may not be relevant to you. It's also important for us to think beyond the neonatal period. And I think this is an area of obstetric medicine which as obstetricians, we ourselves have to come to terms with, because yes, we concentrate about NEC, sepsis, all of that RDS in the neonatal period, but the problems of the growth restricted baby go beyond the neonatal period. There can be neurocognitive problems. These babies are at risk for type 2 diabetes. They are at increased risk for insulin resistance, metabolic syndrome, hypertensive and cardiovascular disorders. And I think, therefore, the care of these neonatal babies, which are born small, has to continue, and this has to be handheld and handed over to the pediatrician so that the care moves on in a cohesive fashion, because it is important for us to understand that the story is not just about birth weight, but about fetal programming, and that actually has an intergenerational impact. So thank you very much for giving me this opportunity to talk about an area which really intrigues and excites me. Thank you so much.
Great.
Yes. Thank you, Ma. Thank you for that excellent presentation. You have made a very difficult area simple for all the obstetricians here. I think Shamim has got a few questions from the audience as well as an experience to discuss with you.
Thank you, Dr. Uma, for that very crystal clear, giving us a crystal clear flow of thought. And we have a few questions in the chat box we'll discuss. And before that, I would like to share one clinical scenario which happened with us, and would like to know your comments around regarding that. We had a primary gravida who is on anti-epileptics, 3 drug anti-epileptics, and then she had a growth restriction was noted from 28 weeks, and the baby stopped growing like after 28 weeks. And in 34 weeks sonar scan, it was same. The baby abdominal circumference was less than 3rd centile, and estimated fetal weight was the same. In spite of the Dopplers, MCA, and the umbilical artery Dopplers were normal.
This is at 34 weeks, is it? 32?
She reached 34 weeks.
Okay.
I mean, she had 3 scans in between the 6 weeks period.
Yeah.
So we had, it was a hard decision whether to deliver in spite of the Dopplers being normal.
Hello. Yeah.
So we had to, we have to counseling. We decided to deliver the baby between 34 and 35 weeks. We had a section done for her, and it was only a 1.3 kg baby. In fact, 1.25 kg baby. Baby is doing very well with the help of our excellent neonatal team. But this is a very difficult situation sometimes, like when the baby stops growing, probably due to the effect of the drugs which she was on. But can you throw light on these situations?
Yeah. So this is similar to that last case that I showed, though there was no maternal disease. I don't know if there is evidence that anti-epileptic will make the baby fetal growth stop at a certain point. There must be some degree of placental dysfunction that is inducing it. Probably if we wait a little bit longer, we would start seeing some Doppler abnormalities. I agree that we are inclined to deliver once we cross 34 weeks when we see cessation of growth, simply because our NICUs are doing such a good job. But if the more recent guidelines seem to suggest that if the Dopplers are normal, provided we can monitor this fetus twice a week, we do a CTG in between to make sure that there are no unprovoked decelerations, we could push till about 30, maybe a week more. But if the abdominal circumference, if the weight has stopped growing completely, there's no difference in 2 weeks, then I think we are justified in delivering this baby.
So Uma, from 29 weeks, do we have to wait till 34 weeks, or after 2 weeks, do you be taking a decision?
So if at 29 weeks I see a fetus which is small and weight is on the whatever growth, evidence of growth restriction, definitely in 2 weeks we'll review again.
There is a question from Dr. Neha Sakir. What about SP ratio more than 3 or resistance index more than 0.6 ACE assessment?
So in general, I know the RCOG guidance talks about the SD ratio and RI, but most of the other guidances and most fetal medicine specialists would only look at the PI. So
what is the indications for immediate?
Would look at the umbilical PI to use your decision-making points.
Okay. Our neonatologist, Dr. Rajeshri, is here. Do you have anything in this context?
Immediate delivery spelling that.
Thank you for the excellent and lucid presentation, Dr. Uma. And for us neonatologists, the most important thing is being an SGA baby, the degree of prematurity in SGA, as you correctly said, that has to be balanced. So has its own risk factors. And for us, from perinatal asphyxia to hypoglycemia, there are a lot of problems that SGA baby faces. And especially beyond the neonatal period, as you correctly said, there are a lot of neurocognitive problems, including short attention span, learning disability, up to the extent of cerebral palsy. And it evidently depends on the cause of SGA rather than the degree of SGA. As you correctly said, the weight is not important, but the cause of SGA is the thing which is important. So we try to arrive at a diagnosis about the cause of SGA so that we can correctly manage the baby.
Dr. Adamani, madam, from HOD, Amrita Institute of Medical Sciences. Madam, I think you have a query. You can unmute and talk, ma'am.
Hello, Dr. Uma. Are you able to hear me?
Yes, I am able to.
Uma, for the second case, the 31 plus 2 days with the 150/90 BP, you terminated terminated that phase. What was the indication for immediate termination there?
Ma'am, there the baby was having intermittent reversal of the umbilical artery in addition to the maternal blood pressure with some proteinuria. So we chose to do an elective delivery because we had reached nearly 32 weeks and there was reversal of umbilical. Even though the ductus was okay, and if I remember correctly, I think we had hit a Friday evening or a Saturday morning and we were not sure about our ability to do Dopplers every 12 hours to see what was happening to the ductus. And we didn't want to section and hand over a tiny 900-gram baby to the NICU in the night if she became hypertensive. I think those were our considerations.
Actually, Doppler result was not shown in that.
Yeah.
It's the reason why I asked.
Yeah, thank you.
There is another question from Dr. Raj Warrior. What is the mechanism of IUGR in neonates with SCID and immunodeficiencies?
The immunodeficiency.
So I think if you have severe combined immunodeficiency, there is an intrinsic problem which is impacting growth, even though there is no placental dysfunction. So there are intrinsic causes of fetal growth restriction. Personally, I'm not aware about severe immunodeficiency resulting in growth restriction, as in I have no personal experience in managing that. But we've had a couple of babies where there was growth restriction. But in those cases, significant, so the AC is hugging like the third centile and then growing. We are sure of dates. The Dopplers continue to be normal. And after delivery, in the evaluation, we've picked up some metabolic problems. So in a similar fashion, if we don't have a clear placental correlation of placental dysfunction based on any Doppler finding, it is very important that you have this baby evaluated for other metabolic and other causes of growth restriction. Let's not just think only placental. Placental is the bulk of it, but given our volume, and the trouble is we don't counsel couples for it. You know? We don't talk to them and say there could be a metabolic problem. There could be some genetic reason why this baby is really small. And then they turn around, tell us you scanned some 10 times, but this is something that has hit us from the blue.
Okay. So another question from Dr. Amit Chose, our pediatric cardiologist. What is the role of functional echocardiography like MPI and tissue Doppler velocities in management of IUGR?
So there are some good studies which have looked at fetal echo and then correlated it with neonatal echoes in the NICU and said that these babies do show a degree of cardiac dysfunction. But I don't think we are routinely doing that to influence management and triggering delivery in growth restricted babies yet. In fact, it will be interesting. We are probably the population who will have the numbers, because one of my areas of interest is these diabetic mothers, or mothers with gestational diabetes who have small babies. And there it would be good to see what's happening to cardiac function also. So there are some papers which have looked at it, but it's not a routine standard of care.
That's fine, Uma. Thank you very much for that excellent session again from all of us from Aster, obstetricians as well as neonatologists and pediatricians. Everybody is very happy to have you here today morning, on a Sunday morning especially. We'll be calling you again.
Yeah, okay. in person. Thank you very much for the opportunity. And I must say that I'm delighted that I will be hearing Professor Nair next. I was a postgraduate, and I still remember he was his passionate plea about rubella vaccination when I was doing my UG and PG. So it will be a pleasure and honor to hear him deliver the oration.
Great. Thank you, Ma. Thank you.
Thank you very much, Dr. Rohan. Thank you.
Fantastic. Yeah. അതല്ല
Is this the slide?
Yes. So, very good morning, everybody. This is my honor to speak a few words about Dr. P.C. Alexander. Very few of us know him, being at Aster, and a few of us are really not known to him. So it is my pleasure and honor to introduce Dr. P.C. Alexander and to speak a very few words about Dr. P.C. Alexander and how he has, influenced our lives and so on. Okay. Now, he was a great human being who touched all of us who has met him. Still remember when he joined Aster at 2014. There was a very small community in Aster, very small community of doctors. But as the department grew up, we later came to know that most of us, as being doctors or anybody who actually knew him were touched by his humanity. Now, a few words about Dr. P.C. Alexander. He was born in 1961 and he expired on 13th February 2018. This was a very disheartening time for all of us knowing him so well. He was actually a very inspiring leader and a very helpful person. But to note the point that Dr. P.C. Alexander's humanity and empathy to everybody was known to him mostly after he had left us. Now, he studied in AFMC, Ludhiana, and had attained degrees from Royal College of Physicians, and is a founder member of many organizations. And also, he had 28 years of experience in the Department of Pediatrics and has been awarded as a Pravasi Award in Sultan Qaboos University. Also, he was the best student and the best postgraduate student wherever he worked in. Now, what is different from him, what we have seen and studied, is the empathy and kindness and innate humanity which carried him as a very special person. Now, he always believed that every child should be given every possible treatment. As Dr. Hari was mentioning a little while back, the idea of a pediatric department in our hospital was very small. However, his vision and perspective was very much different. He believed that every child had to need every care possible, which is why at the initial stage, every department was under the umbrella of so-called child care excellence in pediatric department. Now, if you must know that his degrees and knowledge and expertise and were too much, but although all these things were pertaining to him, what was more important was his human kindness, which excelled rather than everything else. I would like to say one or two words about ASK. So this is an Aster Sick Kids Foundation, which is founded by Dr. P.C. Alexander. Now, Aster Sick Kids has a motive. What it says that patients who cannot afford treatment at Aster or any hospital outside Aster we have a particular way to tackle it. Now, most of these patients will only have to pay around 25% of the total bills, and the rest will be tackled up by a lot of other means. And today, I do not know what is the exact number of how much ASK has been given, but a lot of patients have been benefited with ASK even after so many years after ASK has been started. Right? Now, a lot of patients, this is a patient from pediatric ICU, manned expertly by Dr. Raj. So most of these patients who needed help from pediatric department was given a very great amount of help. Now, the kind of lot of things which has been done as a kind of innovation where a fund could be generated. So this was actually a Christmas exhibition where a small amount of money could be generated, but each and every penny which was generated was deposit in us for all the children. And also, at certain times, what we have seen was he always believed that children did not have voices. So he said, let's be the voice for the voiceless. That was his motive. And many a time he must have visited the orphanages and had helped them in a lot of ways possible. Now, this is one worth mentioning story about Dr. P.C. There was one of the trips when he went to Delhi. This was a picture taken from Saravana Bhavan. So he saw some street kids outside, and they told him, they asked for alms for sure. But then he later found that all the alms was given to these street kids was gone to wrong hands. So he found that out, took them inside Saravana Bhavan and gave them a meal. So the onlooker was a journalist from one of the paper journals. So he took a picture and this was publicized there. So all these things were happening without much of us knowing about it. And also many a times when we have celebrities attending some of the conferences or done in Aster, he would actually get patients from ICUs or other children who really wanted to meet them, so that it's a life experience for all of them to meet some of the celebrities. This was a case again, Mammootty had come into Aster for a film shoot. So she wanted to meet Mammootty as one of her life experience and so on. So what I would like to say was that Dr. P.C. Alexander has changed or given a lot of views and quality in all of us. Although he is not with us physically, we actually have gained a lot of good qualities from Dr. P.C. Alexander. And also, the saying is, where he met a stranger, he made a friend. May his soul rest in peace. Thank you.
Okay. Have a nice day. Bye.
Today, we have with us Dr. M.K.C. Nair to deliver this prestigious Dr. P.C. Alexander oration. And I have the privilege of introducing Professor M.K. Chandrasekhar Nair, DSc, as Dr. M.K.C. He is a renowned pediatrician, counselor, and academician in the field of child development and pediatrics. He has authored over a dozen medical books, holds 12 degrees, not only in medicine, but in various disciplines, and is the academic editor for several test books on pediatrics. Having received the prestigious recognition, please mute yourself, please mute. Having received the prestigious recognitions, including the Dr. Shantilal C. Seth Oration, Nina Sybil Award, and the Lifetime Achievement Awards from IMA and the Trivandrum Management Association, Dr. served as editor-in-chief and executive editor of various publications and journals of the Indian Academy of Pediatrics. With over 200 papers in international and national journals, he has spoken in every city of India and has attended conferences all over the world. Dr. Nair has held prominent positions like the Vice Chancellor of the Kerala University of Health Sciences. He's been the National President of many organizations, the Indian Academy of Pediatrics, National Neonatology Forum, IAP Adults in Pediatrics Chapter, and India Clem. He has been awarded the Fellowship of the Indian Academy of Pediatrics. The highlight of his 40 years of practice was being appointed as the Vice Chancellor of the Kerala University of Health Sciences and later securing the Doctor in Science, the highest degree of science from the government. As a counselor, he has helped 70,000 families, and as an academician, has initiated teaching modules in 3 subjects: developmental, pediatrics, and adults in pediatrics. As an institution builder, he conceived and developed the first child development center in Trivandrum and has trained more than 5,000 doctors, nurses, and other staff in various specialties. Presently, after his remarkable stint as the Vice Chancellor of the KUHAS, he has put all his might behind NIMS Spectrum Child Development and Research Center Trivandrum as his director. I present to you Dr. M.K.C. Nair for his oration. Dr. M.K.C.
Good morning. Good morning, teachers. Good morning, everybody. Thanks, Dr. Jason.
MKC
Dr. Annie Joy,
Dr.
please mute
Jason only
yourself.
introduced here.
Dr. Annie Joy.
Can you hear me?
No, wait a second. I'll just get your
slides. Put a slide first. Yeah.
Yeah.
Okay.
And another narration. Yes, Dr. M.K.C. Nair, you can start. Can you see the slides? MKC? Can you see the slides? Dr. MKC, someone is talking. Please unmute yourself. Everybody, please unmute yourself. Mute yourself. Sorry, mute yourself. Dr. MKC, are you there? Dr. Annie, please mute. Dr. MKC Nair?
Good morning, Jason.
Good morning, Dr. Bodankar. Nice to see you here.
Yeah, thank you, sir. I'm honored to listen to Dr. M.K.C. Nair, my guru, mentor, and past patient. I'm honored, sir.
Thank you so much. Dr. MKC, are you there?
Kindly ask all people to meet.
Yes.
I'm Dr. Tuteja from Indore, sir. Good morning to all.
Good morning to Dr. Tuteja.
Vaheguru.
So let's start the program. Yeah, I'm starting. Actually, can you go back to previous slide? Because Dr. Uma highlighted something. As a postgraduate, she remembered me talking about the rubella vaccine. Probably this is one of the greatest success stories of Indian Academy of Pediatrics, that it is now available free of cost to all the adolescents. So let me start with that. Now, NIMS Spectrum Child Development Center, just one word about it. I am part of it because of one major reason. Any child below 18 with a developmental problem can have a free service. Free doesn't mean that you don't pay anything. Free means that the bill will be made, but you can pay what you can afford. If you can't afford anything, you need not pay at all. Next. Can I have the next slide, please? Yeah. Now, we have been hearing about developmental origins of health and disease for a long time, and simple words, we will call it Barker hypothesis, etc. And there's a lot of work going on in Pune. Yagnik group is doing some great work on that. What is the importance of this? The first time it has been highlighted, the importance of early life growth and nutritional exposure for chronic diseases like cardiovascular, type 2 diabetes, and osteoporosis years later. So what is happening, that undernutrition in the uterus somehow is related to what is happening, the lifestyle diseases later. That is the whole concept. Now it has two parts. One part is there is a clear evidence linking preterm birth and poor growth in utero with worse long-term cognitive outcome. When it comes to preterm, our focus is on poor cognitive outcome. And on the other side, linking more rapid growth in early life. Now I'm putting one more angle, that not only poor growth in utero, but if you have rapid weight gain in the first 1 or 2 years, that also become a risk factor. Now look at preterm and low birth weight. Vast majority of preterms are also low birth weight. That is the third complication. They are preterm on one side, they are low birth weight, but the metabolic and cognitive cost of prematurity compared to low birth weight are different. How different it is, we will come later. So the nutrition strategies and their long-term impact need to be optimized to the individual, and each child, it has to be optimized to each individual, and you cannot have a one-size-fits-all approach for a low birth weight management. Next. So look at the historical background. It is early 1950s. That is when time, maybe within 2 years I was born. So that's an animal study demonstrated some relation between early patterns of growth and later size and metabolic outcome years later. By 80 end and 90 beginning, the translation relevance of the early growth impacts on later adult chronic disease was documented in epidemiological size. First animal studies, it gave the theoretical construct. Now that has been shown in public health, in population studies, it has been shown. So that means it has a clinical as well as epidemiological relevance. Next. Next. Next, please. Next slide, please. Can I have the next slide? Okay. Now, developmental catch-up growth. I'm putting one more, okay, putting one more word called catch-up growth and adolescent outcome. 63 studies led by the team of Lucas and Singhal, and they extended this concept, both confirming the association in many randomized controlled trials in preterm infants, but also highlighting the importance of growth patterns in early postnatal life on outcome in adolescence. So on one side, their whole studies of Singhal group has been mostly on preterm babies who also happen to be low birth weight, or later I'll use the word IUGR. Next. Next, please. Okay, the Singhal group, sorry, go back. Next. Next, please. Next, please.
Next slide.
Jason,
is it next slide?
Problem is this. Okay. Next slide. Go on to the next slide. Just keep moving when I say, okay, good enough. So what is the adolescent outcome following preterm birth? The preterm born adolescents show an increased incidence of, now this is important for you, decreased bone density, increased blood pressure, insulin resistance, abnormal adiposity. All these are surrogate markers for later adult metabolic disease, chronic diseases. So I think I'll repeat this. Any study you look at it, you will review more than 1,000 studies on this. Any study you do review, you will find one of these in multiple different combination. It will all show decreased bone density, increased blood pressure, insulin resistance problem, as well as the abnormal adiposity. But when it comes to preterm baby, the classical difference is impaired cognitive outcome, which may be or may not be there for the low birth weight babies. Next. Next. Okay. Adolescent outcomes of 17,000 preterm and nearly 3 lakh term babies. What does it show? Preterm birth was associated with significantly higher systolic and diastolic blood pressure, increased levels of low density lipoprotein. So blood pressure on one side, hypertension issues. On the other side, the metabolic, mostly low density lipoprotein. A series of well-characterized cohorts showed evidence of insulin resistance in individuals, that is at adolescence born preterm. So you have all the studies coming to large studies showing this. Now this is a classification of birth weight. All of us know low birth weight, very low birth weight, extremely low birth weight. But what we need to focus today is much more the small for gestational age, appropriate for gestational age, and LGA, large for gestation. Because later on my studies have shown that most of these results that we are talking about are only for small for gestational age. That's why I'm showing this slide that I'll show later. Next. Now, what is small for gestational age? It is estimated that 32 million babies were born SGA in low and middle countries, which forms about 27% of all birth as per 2010 data. But most important is India has the world's largest number of SGA birth. 12.8 million in 2010 due to the large number of birth on one side and high level of low birth weight. Okay, so low birth weight proportion is almost 47% of birth that are SGA. That's very important. 40 out of the low birth weight also 49% are small for gestation. That's very important. Now, this is a technical part of that. On one side, you have preterm, full term. On the y-axis, you have low birth weight, normal birth weight. And this graph can be shown like a, the line drawing on above is AGA, below is SGA. You can show a thicker line showing the range of appropriate. That we are not shown here, AGA and SGA. Next. Next, please. So, what is the association of low birth?
Hear you, Dr. MKC, you're not heard. MKC. Huh? MKC is going out. Hello, we're sorry for this interruption because Dr. MKC Nair's line got cut. He's trying to log back on. He's joining back.
Okay, can you hear me?
Yeah. Okay.
Okay, next slide, please. Next slide, please.
Yeah, I'm just starting. Did you see the next slide?
Yeah, next one. Next.
Yes.
Okay, now let us, okay. Now what I will try to say is 25 years of follow-up at CDC Kerala. My low birth weight babies who started on 1st of August 1987, when they were followed up till 24. Now they are going to be again followed at 35 years. So let us look at what are the waves that we are. The wave 1 was 0, birth, 1 year, 2 year. Wave 13, 16, 19, 24. And the number of babies who have data on all 5 visits. Individually at 13, 16, 19, 25, we have much larger number. But to compare the data, what we have done is took only those cases in which all the 5 waves we have the data. So that is what is shown: 96, 86, 67, 73, which means not much of loss to follow. Next, please. Okay, so wave 1 is birth 2 years. What are the things that we have found? The babies with IUGR had naturally anthropometric measurements at a lower end of standard deviation, but by 2 years, they caught up with the non-IUGR group, which is expected. We know that. There were some perinatal factors, family factors, but what is important is birth-related factors. Birth weight, length, and head circumference were significantly lower. Weight, length, and head circumference and motor age at 1 year were statistically significantly lower in the IUGR group compared to non-IUGR group. That means weight, length, head circumference, and motor age at 1 year less. The importance is that why we need to do a follow-up 100% minimum up to 1 year, and also do a Bailey scale to get all this. Now at 13, the moment they were adolescents, the weight between IUGR and non-IUGR groups were different. The prevalence of BMI, fat percentage, average systolic blood pressure abnormalities were higher in the IUGR. So whatever I have said from literature, now it is coming true. The BMI, fat percentage, and average systolic pressure abnormalities were much higher in the IUGR group. But the height and age of menarche were not different, because some studies show that they have delayed menarche. But in our study, the larger group, we found height and age of menarche were not affected. Next, please. Yeah. Now, wave 16, what we found is triglycerides and very low density lipoprotein cholesterol levels between IUGR and non-IUGR was different, with the IUGR group having higher values. That means at 19 or 16 also, we are finding the same finding, that the difference between IUGR and non-IUGR is continuing. Waist-hip ratio was higher among those in the IUGR group. Similarly, significantly higher levels of triglycerides and very low density lipoprotein cholesterol were seen in the hypoplastic subtype. Among the IUGR also, you have 3 groups. The hypoplastic showed the effect more openly, more relevantly. Next. Now let's come to critical 19 years, where the prevalence of low height and weight, of course, was there naturally, as we were showed earlier. But apart from that, there was higher BMI, higher fat percentage, waist-hip ratio, and average systolic blood pressure. It was more for the IUGR group. So clearly showing that IUGR group, even at 9 years, their BMI is different, fat percentage is higher, waist ratio is different, blood pressure is higher. And waist-hip ratio was significantly different among subtypes and higher among malnourished group of IUGR. Malnourished group, that is the most important part. Next, please. Let's come to 24 years. Now, when you come to 24 years, again, one by one, we need to go. Height, weight, and IQ of young adults were lower in the IUGR group, and they showed a trend towards statistical significance. Height, weight, of course, we said earlier, at 24, the IQ of young adults were lower in the IUGR group. IQ, height, weight, fasting insulin, glucose insulin ratio were significantly different between the groups with, just go back, with weight, mid-calf circumference and lower. They were lower in the hypoplastic IUGR group. Hypoplastic had much more problem. The mid-calf circumference is very important because in cardiovascular epidemiology, a lot of importance is being given to calf muscle size and calf pressure. Lots of studies are done. That's why this is important. Although the comparison of mean values do not show, forget about it. There is more young adults with hypoplastic IUGR with all these problems in the more in the IUGR group. That's the most important thing. Next. Next, please. Next. Okay, now the metabolic syndrome. How do you define metabolic syndrome? International studies, many different ways have been used, criteria have been used, but those criteria cannot be used at 24 years because they are not yet developing metabolic syndrome, they are developing pre-metabolic syndrome. So what we have done is, instead of using the international standard, we use 90th percentile of standard cutoff. For example, you take established metabolic syndrome is defined as +2 standard deviation of sample mean to define as abnormal. And to say emerging metabolic syndrome, 1 standard deviation. You take the whole sample, 1 standard deviation is taken as emerging metabolic syndrome and 2 standard deviation as metabolic syndrome, because the clear-cut metabolic syndrome is likely to be shown only in the next follow-up at 35 years. Next. Next, please. Yeah. Now let's look at what are the model. We have developed a clinical model used there. What are the factors that has come significant in the analysis? IUGR, of course, clear. Sex, male sex, 10 times more odds ratio. The weight at 1 year. Again, we said if you have a rapid weight gain in the first year, it's a risk factor. That is 6 times. And then, of course, average systolic blood pressure, diastolic, fat percentage, and very low density cholesterol, odds ratio 4. Now, these were the predictive factors that can build a model. That model, I won't give all the details, but this is a factor for the model. Next one. Now, let's look at the community use. In the community use, almost same, except that we removed the cholesterol. Now, this is important because in a country like India, where you have large number of adolescents, to do a blood test is not ideal and not possible because it has its own other complications. So we were looking whether can we have a model in which without touching the child, you can get it. IUGR get from the history, male get from the history. Every mother will remember the weight at 1 year, if not at 2 years later, but 1 year weight, most mothers will remember. You can take the blood pressure, you can measure the fat percentage by a simple tool. It's not difficult. It's something like a weighing machine. It's not totally accurate for a research, but clinical purposes, good enough. Next. Next, please. Now, this is a very important slide. What does the study show? Young adults born, IUGR is 3 times more. You can take a screenshot of this one single slide because this is important. If you are born IUGR, you have 3 times more. You male 11 times more. 1 year weight, if it is over, rapid weight gain 6 times more. And 16-year very low density lipoprotein cholesterol 4 times more. 3, 11, 6 and 4 more risk for emerging metabolic syndrome. This has been conclusively shown. Of these variables, VLDL, suppose you remove the cholesterol from the thing, it becomes a community model. So even without that, is it good enough? That's the next thing. Then we had to do a diagnostic accuracy of the clinical scorecard made. And I'm sure you understand sensitivity, specificity, forget about likelihood ratio for the time being. If what is appropriate when you do an ROC curve is the score of 12 has 100% specificity and you have a 20 sensitivity. You can do, even if you take 11, it's 25, 14, 12. So I think 12 would be, because we want specificity as 100%, there cannot be one mistake. Next one, please. Now, look at the community scorecard. Here, remember, community scorecard do not have cholesterol level, low density cholesterol. All the rest is there. Here also what we find is 12 would be an ideal score with 100% specificity. Of course, sensitivity is a little less, doesn't matter. Next, please. Now, this is an important slide. The ROC curve, area under the curve. If you look carefully, see on the right side, you have two type of lines are merging. One is a straight line, second one is dotted line. One is a clinical scoring, dotted line is a community scoring. I think looking at it, you cannot differentiate the two, which means both are exactly going identical, merging one with the other, clearly showing that there is no need for low density cholesterol. There is no need to draw blood. You, in an adolescent at a school leaving SSLC or 10, 15 or 17 years, all you have to do is ask the birth weight, see whether it was IUGR, look at the weight at 1 year to see how much rapid weight gain is there. Look at the, what do you call, BP, BMI and cholesterol. In a clinic situation, the cholesterol, community school situation, no need for cholesterol, and you will get a good prediction. Area on the curve is very high and it is statistically significant. So clearly showing that you can do a study, you can do a clinical assessment of every child leaving SSLC or +2 and say whether they have a chance for metabolic syndrome. Now, the second issue is prevalence of intelligence abnormalities. Now, look at intelligence abnormalities. I'm not showing the whole detail. I'll only show one slide. The prevalence of subnormal intelligence based on VAPIS total score was higher among those born IUGR than with non-IUGR. That means IQ score is lower for the IUGR group, higher for the non-IUGR. Among the IUGR subtype, hypoplastic followed by malnourished had more problem with intelligence. Look at the red part, IUGR 4.9% with the intelligence problem, hypoplastic 10%, malnourished 4.9. So total average 4.9, but if you differentiate, much higher one is being shown. Next. It's a Wechsler adult intelligence scale. Now the same thing, you do a multivariate predictive model, what we are finding is, number one is IUGR to predict the intelligence. 11.7 odds ratio, maturity, premature or not, maturity of the baby 3.8, education of mother almost 3, and then you have mental age at 1 year 4.4. Now remember, previously for metabolic I showed the motor age at 1 year was predictive. Here the mental age at 1 year is predictive. That is why at 1 year in any NICU, you should have a Bailey scale done at 1 year, absolute minimum, because this is a predictive model that we are getting in. Next, please. Now, what about mental health problems? Anxiety, depression, etc. at 24 years. What we find is, again, in the IUGR 4.8, 5% having mental health problem, that non-IUGR 5% having, the IUGR group 12% having, more than double. And in the particularly look at major depression, just focus on IUGR, 12% have problem compared to 5% in non-IUGR, then 10% having major depression and 15% having anxiety. And particular observation is the hypoplastic babies had 33% of them had anxiety. Now, this is something we all talked about metabolic syndrome. Sometimes we talked about intelligence issues, but in the literature, most people do not look at the mental health problem at adolescence. So it is important that if they have this problem, then it is important to look at the IUGR, whether what weight they were born. Next, please. Now, what is the clinical significance of all this? We know that Kerala is one state where we have a score. IAP Kerala had made a contributed to the government a score called, a book called -2 to +2. What does it mean? When the baby get into the LKG, you have all details entered, and till +2 same card is kept. Okay, now with the new education policy, it will become 3. It's a pediatrician responsibility to fill up this form. So just go back, please. Just go back. Okay. Now this is the adolescent health card. You can, on one side you have height, other side you have weight. You can teach the child to take the weight. We don't have to go and do it. The children can look at take the height and weight and map whether they are in the green zone, which is normal, red zone above obesity, and red zone below this one. Now preventing, next one please, next please. Now preventing, next one, this is a very important concept. Now, when you want to reduce low birth weight, umpteen number of studies have shown, particularly Hirve et al. In Pune, they have looked at 50,000 pregnancies and that given attributable risk for, what are the attributable risks for low birth weight? And they found many things. First, of course, was the height of the mother was the most important, anemia, many other things. Height of the mother, not the weight. Height was the most important. Now, height is important. We need to know that the adolescent girl's height spurt is just before the puberty. Once they have the menses, any amount of nutrition given only make them fat. It will not increase the height. Now, how do you know when the menses is going to come? The mother, when she is bathing the baby, or the doctor, when you're examining the baby, put the stethoscope. If you feel a small breast bud coming up, then within 2 years, she will have menses. Those golden 2 years is the time to feed the baby, really feed the baby, because it will only contribute to height, not so much to weight. Whereas once she has menses, if you give it, and this has been given to Government of India as a national policy document, and it is going to come in the next plan, most probably. Last plan, they had other priorities, so they said, we will do it in the next one. Now look at this next one, please, next. This, all of us talk about it, but we don't practice. Just remember one thing, the size of the burger, the size of everything has to be reduced. That is all. Now, don't tell the adolescent, don't eat this, don't eat that. They are not going to listen to you. But at least reduce the size. Secondly, just like you eat junk food, which you should not be eating more than once in a week, you also focus on eating vegetables, and that should become a fashion. And COVID times, this is something that's happened in many houses. Because they had nothing else can be done, they were actually having their own vegetables without poison, and eating of vegetables has become a habit in the many houses. Next. Now, this is another important policy implication, and that is, next please, that is, once you have obesity, the obesity never go away. The reason being, when you have increased energy intake, the fat cells increase in number, not size, increase in number. And once it has increased in number, if you eat less, you become tummy will go in. But the moment you eat more, it will come back. So once you are obese for life, so long as you eat more. So what the important thing is to avoid obesity for these children in the adolescent period. Next. Next. I think 1 or 2 more slides. Now this is a classical slide we use to tell that most adult lifestyle diseases have their origin in childhood and adolescence. And studies say that at 15, if you do this, obesity, hypertension, dyslipidemia, insulin resistance, smoking, you need to add one more based on this oration, and that is IUGR. If you are IUGR, it is even more. That's the point. Next. Next, please. Probably the last slide. Next, please. Okay, now this is the last slide. So for a low birth weight baby, what is a pediatrician's role? we need to emphasize the 10 commandments, which normally we do for all children, but low birth weight baby, we need to do with even more vigor. That is no tobacco, no trans fat. Sorry, go back, please. Go back. Just go back one slide. Yeah. Reduce salt by reducing pickles and puppet. Reduce sugar, sweets and chips. Reduce cholesterol by eating less of fatty food. Reduce stress levels. And this is important. Now, why do you have stress? Because you become jealous of others. Stop jealousy, you won't have problem. Reduce TV and computer time, which is not possible now in the COVID time. Increase physical exercise, increase fruits and vegetables, and increase the family, time, quality time together. So these are important for all adolescents, but even more important for a low birth weight baby who is programmed for adult diseases like cardiovascular, the diabetes, as well as, of course, obesity and the mineral loss. You have the problem with the bones. So in this context, should be the challenge of every clinician and public health person to use the scorecard when you assess a child, and we have actually started using it in the adolescent clinic of NIM Spectrum Child Development Center. Thank you all very much for a patient hearing.
Thank you so much, Dr. MKC Nayak, for that excellent presentation. The oration was something that we have all been waiting for. We'd like to, Dr. Joseph, would you like to say something?
Yeah, it was a fantastic talk, and given us light on many of the things, especially this obesity aspect is one of the major factors which is happening all around. And thank you for putting a lot of light on that aspect. Thank you.
So, as part of the thanks and gratitude on behalf of Aster Medcity, on behalf of Dr. P.C. Alexander, who we remember, we as whole hand over this plaque. Thank you so much. We will be sending it over to you. We have
I'm
this.
Receiving it.
Yeah,
I'm receiving it.
The certificate. This is
okay, I'm receiving it.
Yeah. And the Kannada, which we couldn't put on you, but we would have loved to have you with us. It is an excellent. We have had some very, very, very important people doing the oration, and this time we are so thankful that you could help us out and do this oration for us. It was excellent. Thank you so much, Dr. MKC. Thank you.
Thank you.
Now we will go on to the next presentation by Dr. Christopher Harris.
So let me take this opportunity to introduce Dr. Chris. Dr. Chris is Dr. Christopher Harris, is a neonatal consultant at King's Hospital at London. His research focus is mainly on neonatal ventilation and long-term outcomes of prematurity. And more introduction will be done by the moderators later on. I would also like to introduce the moderators for this session. We have with us Dr. V.C. Manoj. Dr. V.C. Manoj is the past president of IAP Thrissur, president of National Neonatology Forum, and HOD of Jubilee Mission Hospital. And he has many journals. He's a very good teacher and academician. We would like to thank Dr. V.C. Manoj for coming to us for this session. Now we have Dr. Radhamani. Dr. Radhamani Madam is a head of departments in Amritsar Institute of Medical Science. She's a great academician and a very good teacher. She's received a Best Professor Award, and she's a UG and a PG examiner, and she's lots of publications under her name. We thank you, Madam, for coming to our conference. We have with us Dr. Joseph Paul. Dr. Jospol has 25 years, more than 25 years of experience in neonatology. He has worked in many places like in Oman and in UK. And his main area of interest is neonatal transport and preterm nutrition. Currently, he is the HOD of neonatology at Aster Medcity for the last 5 years. We are honored to have Dr. Jospol with us. Over to the moderators. Dr. Manoj.
Am I audible?
Yes, yes.
Respected seniors and my dear friends, at the outset, let me thank the organizers for having asked me to jointly moderate this great session along with Jospol sir and Adamani madam. Right from the embryonic stage of fetal lung development, all through the neonatal and infantile alveolar stages of development to the adolescent period and beyond, lung development is a fascinating story. The story of lung development actually has evolved as neonatologists has evolved from the conventional ventilation of the previous century to the non-invasive ventilation, volume-targeted ventilation, lung protective strategies, and so on. So this is a fascinating field for all of us, and now we keep looking at the long-term outcomes, just like MKC sir was talking about the outcome of growth restriction. Probably the way we manage the lung also has lot of story to tell us in the future. So I will not, we are all eager to hear the story. May I request Dr. Jospol to kindly throw more light on the speaker who is a guest for all of us. Dr. Jospol.
I'm sure many of you or some of us at least heard about Dr. Chris Harris. He's a well-known neonatologist, even though I have not worked in King's, but I was not very far off. I was at Medway Hospital in Gillingham. So I used to go to King's and I remember seeing him a couple of times, and when I used to do some transports, basically. Okay, Dr. Chris Harris, a neonatal consultant at King's Hospital, London. His research focuses on neonatal ventilation and long-term outcome of prematurity, undertaken at King's College Hospital as part of the neonatal respiratory physiology team headed by Professor Anne Guino. As well as he was working in London, while he worked as a consultant pediatrician and neonatologist in Uganda, working to improve the neonatal outcomes in low resource settings. Chris also has a keen interest in drawing together the experience gained from those looking after the premature infants around the world to help to improve our knowledge and understanding of prematurity and ultimately offer brighter futures to our infants and our families. Basically, today's talk is of more relevance. Basically, we know that the main issue when a premature baby comes is the lung, the respiratory issues, and if the baby breathes, and if you can get out of the respiratory issue, then we can, most of the other problems, we can someday manage. So this is going to throw a lot of light on the respiratory aspects of a newborn baby and the lung development, and let us hope that we are going to have a real feast of information. At the same time, can I remind the delegates to keep ready with your questions and keep posting it so that, we can accumulate it and we'll probably get the answers from our speaker. Please. Over to you,
Chris. Chris, will you be sharing the slide yourself?
Yes, thank you so much. If you could just accept my slide share request.
Yes.
Can you see those slides now?
Yeah, we can see that.
Perfect. Are you ready for me to begin?
Yes, please.
Please do.
Okay, first of all, I'd just like to say thank you so much for inviting me to talk at the Monsoon CME conference. It is of huge honour to me to be a part of such an esteemed delegation of paediatricians, neonatologists, and other specialists as well. It's particularly difficult to follow Professor Nair, whose topic is one that's very close to my heart, but particularly the long-term outcomes of our infants that we see on the neonatal unit all too commonly. What I'd like to focus on, with your permission, is the long-term effects, particularly related to the lung development that we see associated with premature infants born in the UK. Oh, sorry. We often see these small infants who require intensive therapy in their first few days. And these young infants go on to give us an all too common picture of lung hyperinflation, patchy consolidation, and also an oxygen requirement, which can persist for several days and months and even go on to give us bronchopulmonary dysplasia. As neonatologists in the United Kingdom, we often follow these infants up, even up until 2 years. And so we are quite well versed with our infants going home on some oxygen and requiring that oxygen for some time. And that's been the basis of most of our research in this country, looking at the combined outcome of bronchopulmonary dysplasia and death in our neonatal population. But the story is very much changing as we realize that these small babies who have an oxygen requirement often go on to become small children, such as these 13-year-old boys who are quadruplets born at less than 29 weeks. And beyond that, these children grow up to be young men and women who play an active role in society. And as well as our understanding that this journey continues beyond our unit, parents are also asking us, what does it mean for their premature infants in terms of the long-term outcomes? What are their small babies going to be able to do when they reach the age of 18 and beyond? And so what we at King's have been doing is looking at a group of young infants who were recruited at less than 29 weeks of gestational age, who were involved in the United Kingdom oscillation study. And this was a multi-centered randomized trial, which randomized infants less than 29 weeks within 2 hours of birth to receive either high frequency oscillation or conventional ventilation. And these infants were followed up at 11 to 14 years by Sanja Zivanovic. And then I've been following them up as part of my PhD at 16 to 19 years as well. And this cohort is unique as neonatology has changed very much across the years. And we now routinely use antenatal steroids, which we give to the mothers prior to delivery, and also surfactant once infants are born. And those two interventions by themselves has very much changed what we see in terms of the lung disease associated with prematurity, with the older bronchopulmonary dysplasia of severe pressure-related damage to the lungs with lots of pathological signs and X-ray changes, to this newer bronchopulmonary dysplasia where the lungs look very different under a microscope, but indeed even infants who have no ventilation at all can sometimes have an oxygen requirement that persists beyond that initial neonatal stage. And it's very important to recognize these changes in neonatology, because it means that some of the studies that we've done in older populations may not be completely representative of the populations that we are seeing and indeed creating in our neonatal units today. And so what we want to do at King's is to try and investigate the long-term outcomes of these infants, because as well as the fetal stage of lung development being so important, and we also know that the pubertal growth spurt is associated with a dramatic change in both the airways and the lung parenchyma. And that this is in fact the last positive effector of lung function before people enter into adulthood. And if I just show you that graphically, this drawing by Bolton et al. In thorax brings this quite nicely together, where you can see that you reach your lung function potential in the first 20 or so years of your life. And then your lung function slowly deteriorates as you go into adulthood and in fact beyond. And this is of importance to us, because if I show you this data from a population study, and this was the Tasmanian population study in Australia, you can see that your lung function at 18 years of age, if you were in the lower lung function group, it gave you a much higher chance of developing COPD later on in adult life. And if we assume that our premature infants have some degree of lung difficulty, and that there might be interventions that make that better or worse, it may be that we are creating a large population of young adults who might go on to have significant lung disease in adulthood, but also that has implications for our healthcare settings as well. So let's look at some of the effectors of lung function and try and put that all into context. In many ways, the lung function of a premature infant is decided at the point of conception, and that's when infants are decided to be either boys or girls. And we know that the androgen receptors are present in the lungs throughout fetal development, and also that androgens themselves can affect the cells of the respiratory system and affects the way they branch and form alveoli. And indeed, different concentrations of these hormones, as is seen in boys and girls, can inhibit surfactant production. Indeed, when we look at adult studies, we know that the female fetus reaches surfactant maturity earlier than its male counterparts. And this has a significant effect on the neonatal outcomes that we see in our patients. And this is research from our study group at King's, which shows that whilst the male fetuses tended to be a little bit larger, they had a much higher rate of death or bronchopulmonary dysplasia, and also major cranial ultrasound abnormalities as well. But beyond the neonatal period, when they reached 2 years of age, they had a much higher chance of disability, cognitive delay, and the need for steroids and bronchodilators. And this is something that was decided long before the babies were born. What we did at King's was we looked at the lung function of these boys and girls when they reached 11 to 14 years of age. And we were able to show quite clearly that these differences that we'd seen in the neonatal period persisted into childhood. And indeed, particularly in scores of airway function. And I've just highlighted those here in the red boxes. Airway function was significantly poorer in males compared to females. But not only that, but they had higher rates of gas trapping, something that's associated with asthma. And so this is a real world outcome for these children, and something that we can talk about when babies are on the neonatal unit. And we've just heard some really wonderful data and explanations of the metabolic consequences of intrauterine growth from Prof. Nair. And I'll just dial that down to the specifics of lung development. And so we know that poor intrauterine growth leads to hormonal changes in the mothers themselves, and that these hormonal changes lead to disruption of the insulin-like growth factor axes in the fetus. And indeed, when we induce poor intrauterine growth in sheep, the sheep, when they are born, have structurally different lungs to those sheep that are well grown, in that they have fewer and larger alveoli. But interestingly, these changes are not just present at birth, but they persist into the future as well. And so we at King's, we're interested to see whether these changes that we could see in the animal studies could also be detected in our ex-preterm population. In terms of what's known in the media, in the literature, the results are rather conflicting. And I think a large part of these conflicting results come from what I was talking about earlier, which is how neonatology has changed. And in these pre-surfactant studies, there are some studies that have shown that intrauterine growth has a significant effect on lung function, and others that show that it has no difference at all. And so what did we find when we examined our children at 16 to 19 years of age? Well, again, we saw differences in airway function, such as the FEV1. But interestingly enough, even at 16 to 19 years of age, and this is after that pubertal growth spurt, we were still seeing that whilst the total lung capacity was conserved, these infants had a higher residual volume and a higher FRC. And this suggests that, as in the animal studies, our children had bigger and baggier alveoli. And in fact, when we looked at the diffusion capacity of carbon monoxide across the alveola, we were able to show that these bigger, baggier alveoli were also less functional. And so this might mean that intrauterine growth is associated with poorer lung function, but also poorer functional outcomes as well. And I'll come on to that at the end. No talk that looks at in utero effects would be complete without discussing in some way the effects of intrauterine infection. And we know that the intrauterine infection is something that's associated with preterm birth and might possibly have an effect on the outcomes of our infants born prematurely as well. And the recent Cochrane reviews of chorioamnionitis in particular are less clear of the effects of infection in the uterus. But if I show you these two slides of lung tissue from infants who have been subjected to, or at least their lung cells have been subjected to endotoxin, which is a feature of bacteria. And you can see that the lungs of the controls are significantly different to the lungs of those treated with endotoxin. But if I also show you the effect of betamethasone, which is a steroid that we use commonly in the prenatal phase or the pre-delivery phase, you can see that the effects of steroids are also quite significant as well. But dialing that down, and what we also know is that inflammation in general is an important factor of prematurity. And we know that inflammation in the neonatal period, particularly higher levels of inflammation, is associated with these poorer outcomes of bronchopulmonary dysplasia and death. And we know that the mode of delivery can affect the way the immune system of the baby is primed and how it then goes on to respond to inflammatory stimuli such as infection. But little is known about the long-term effect of this inflammation on the lung function of those prematurely. And so what we did was we looked at the mode of delivery and the effects on lung function as a surrogate to that. And we found that there was no difference between those born by caesarean section and those born by vaginal delivery in terms of their lung function. However, what we did recognize was that a large number of infants who were born by caesarean section, the mothers had actually entered labor prior to delivery. And so when we looked at the onset of labor as a factor, we found that the airway function, particularly the small airway function of these prematurely born infants when they reached 16 to 19 years, was significantly poorer in those whose mothers had not reached established labor prior to delivery. And so these data suggest that, in fact, it's the onset of labor that helps in the priming of the immune system rather than the mode of delivery itself. So these are in utero effects, and we rely very heavily on our obstetric colleagues to help us with these factors and to time the delivery so that these factors are minimized in our neonatal population. But what about when the babies are born? Because when the babies are born, they come to us, and it's our job then to make those decisions to try and affect the future of these poor babies. And as was touched on earlier, one of the things that's been heavily studied in neonatology is the mode of ventilation that we offer our babies. And it's very clear to us that, in fact, there's no mode of delivery that is completely damage-free. These lungs, these premature lungs, are not meant to be used for at least another 2 or 3 months after delivery. But we have no other way currently of getting oxygen into our babies and therefore helping them to survive. But we know that by using those lungs, we can't help but cause some damage. And also it's clear that it's not so much the pressures that we use to distend the lungs, it's actually the volumes that we deliver that is the main determinant of the lung damage that we see. And I've just put up one animal study, but I could have chosen many that have shown that. And so one intervention that we have tried is to try and limit the volume that we the tidal volume that we deliver to these preterm lungs. And we've tried to do that by using high frequency oscillation, which uses a tidal volume of 1 to 3 mils per kilo, as opposed to the 5 to 7 mils per kilo that we normally aim for with conventional ventilation. And the United Kingdom oscillation study is still one of the largest trials of neonatal ventilation to this day, but it showed no difference in bronchopulmonary dysplasia or death between those who were oscillated and those that were conventionally ventilated. And these results have been confirmed by subsequent studies, and indeed a Cochrane review that was presented in 2015. However, when we looked at their lung function when they were 11 to 14 years of age, Dr. Zivanovic was able to show that those who received oscillation ventilation rather than conventional ventilation had better small airways function when at 11 to 14 years of age. And this was a significant finding because it was one of the first that showed that there might be a benefit to oscillation, if not in the early outcomes, then in the later outcomes as well. And it's worth remembering that the premature neonates, there's very little that we can do to study their lung function. And so it's really only until you get to 11 to 14 years that you might be able to ask them to breathe into a tube and agree with us when we're trying to do our testing. And so questions turn to why this might be the case. Why did we see a difference at 11 to 14, but not in the early stages? And we focused on these inflammatory interleukins that when we did this, most clinicians hadn't heard of interleukin 6. And it seems with COVID that we've certainly improved our knowledge of these two interleukins quite dramatically. But interleukin 8 and interleukin 6 are produced by alveolar cells, and particularly type 2 alveolar cells. Indeed, they're produced by many cells of the respiratory system. And whilst they're produced at high levels of stretch, the production of these interleukins are exponential. And so there are very low concentrations at low levels of stretch, but very high levels of concentrations at higher levels of stretch. And the concentrations are not linear. And what we did was we grew type 2 alveolocytes onto flexible membranes, and we stretched them to simulate both oscillation and conventional ventilation. And then we measured the concentrations of interleukin 6 and interleukin 8 in the media. And we were able to show, and I'll just highlight that by these two red boxes, that the concentrations of interleukin 8 here, but also similar for interleukin 6, were significantly higher in those infants that were conventionally ventilated compared to those who received high frequency oscillation. And this is important because interleukin 6 and interleukin 8, whilst they are a feature of inflammation, and they're also a feature of non-inflammatory lung disease as well, such as pulmonary interstitial fibrosis in the adult. And these are diseases that, whilst they are non-inflammatory, they are typified by high levels of fibrosis. And we know now that the scarring and the fibrosis of lungs happens almost independently of inflammation in these infants. And so we may not have seen a difference in the neonatal outcomes of bronchopulmonary dysplasia and death, which are highly inflammatory driven. But the scarring that these infants are left with, it might be due to the different ways that we're stretching them as babies. I'll just skip over this. And just this month, we have presented our follow-up data of the 16 to 19-year-old patients, which has further muddied the water almost, where we were not able to show the same differences in lung function of these late adolescents who'd received high frequency or conventional ventilation. in contrast to Senya Zavanovic's study. And what this might show is that the pubertal growth spurt that these children went through as they became young adults has actually allowed those who had poorer lung function to catch up in some way to those who didn't. And so I think the story of immediate postnatal support in the long-term effects is still an area that needs further investigation and more science to try and separate what is right and what we should do. So moving on from the ventilation itself, once we start ventilating, we are very keen to get babies off the ventilator as quickly as possible. And one way that we can do that is the use of postnatal steroids. And it's been shown in Cochrane reviews that the later use of postnatal steroids in particular is associated with a lower mortality and indeed in some ways a reduced incidence of bronchopulmonary dysplasia as well. And this was with no significant increase in neurodevelopmental problems. However, I should highlight that in this Cochrane review, in the vast majority of these studies, the infants, even if they were in the no steroid arm, did eventually receive steroids further on down the line. And so it's not possible using these data to draw conclusions, particularly about the incidence of neurodevelopmental problems. And amongst the longer term studies, again, the evidence isn't very clear. And in these studies that I've presented, which are all in the pre-surfactant era, there are some studies that suggest a difference and some studies that suggest no difference. But all of these studies are relatively small and might not be in a population that represent our current neonatal cohorts. So we first looked at the effect of postnatal steroids on the lung function of 11 to 14-year-olds. And we were able to show that those infants who received steroids had poorer airways function compared to those who did not receive steroids in the postnatal period. And I'm be very clear here, these are infants that received steroids after they were born, not those that received antenatal steroids. So the question was asked after we presented this data as to whether we were just measuring those infants who were sicker and required steroids to get off the ventilator versus those infants who floated through the neonatal period without much respiratory support and were very much better. But we are in some ways blessed in the UK that no hospital really agrees on steroids. And so there are multiple different regimens for steroid delivery, and certainly more so back in 2000 when this study was performed. And so we were able to go back and look at the different steroid regimens that were available at that time. And we were able to show that in hospitals that used less than 7 days of steroids versus those that used more than 12 days of steroids as their first line treatment, that actually it was the amount of steroids that these infants were subjected to that was more important than the receiving of steroids alone. And so those that had more days of steroids had worse lung function than those that had fewer days. And this was, again, particularly seen in the small airways. So we were very keen to see whether that pubertal growth spurt that had overcome the differences in our oscillation trial, and whether those differences were still seen at 16 to 19 years of age. And in fact, those differences were still seen in our post-pubertal population, with those who had received steroids having significantly poorer small airways function when compared to those who had not received steroids. But it's even more worrying than that, because when we looked at the longitudinal data, we were able to show that in those who had not received steroids, their lung function actually improved through that pubertal growth spurt, which is what we would have expected. But in those infants who had received steroids, that pubertal growth spurt was affected and their lung function actually got worse. And so we were having an effect, something that we had done in the neonatal period had gone on to affect not just the neonatal lung growth, or in fact the childhood lung growth, but indeed the pubertal growth spurt as well. And this is not too surprising when you consider the global effect of steroids. It is like a sledgehammer to the premature neonate. And when we look at the animal data that shows that if you give dexamethasone to prematurely born rats, the rats end up to be 30% smaller than others in the same litter who do not receive steroids. You can see that these results are both plausible and concerning as well. So I've presented a lot of lung function data, but certainly in the neonatal world, we are often accused of using outcomes that aren't important to our patients. Certainly, parents are less worried in the UK about whether they go home on oxygen or not, and more worried about what that oxygen requirement means to children later on in life. And so we were keen at 16 to 19 years of age to see whether this poor lung function might have a functional deficit for our population. And when we look back at the literature, it was clear that prematurity itself has a significant effect on exercise capacity, with almost a linear relationship to gestational age and exercise performance. Indeed, infants born prematurely tend to exercise less regularly than those born at term, and indeed they feel less fit as well. And so when our cohort came to King's to undergo lung function testing, we also asked them to do a shuttle sprint test. And this is a test that has been shown to have correlation with the VO2 max, which is the gold standard. It's also been shown to be reproducible. And we combined this assessment with asking our study participants how many hours of exercise they did per week, so much so that they got out of breath or sweat. And our results were very interesting. We were able to show that in those with abnormal lung function, they had a poorer exercise tolerance when compared to those who had a normal lung function. And you can see here that the difference, the mean difference is about 110 meters. And when you look at the data for this shuttle sprint test, any distance over 50 meters is considered to be significant, and any distance over 75 meters is associated with significant side effects and significant symptoms. And so this distance that we've measured here may be an indicator of limitation of these young adults in what they can do day to day. And it shines a light on this lung function data, that it is important for us to try and modify as much as we can the long-term effects that we are producing by our neonatal management, particularly on the respiratory system of those that we're seeing. In addition to that, it gives us all pause for thought when we are seeing our infants and happy when they are discharged from us off of oxygen and waving goodbye to them, that these infants might need longer term follow-up in order to try and maximize the lung potential that they might have. To that end, we've started working a lot more closely with the respiratory physicians at King's in order to try and improve things for our patients. So I'll end with a summary that there are, in fact, factors that affect lung development beyond just the degree of prematurity, and that we as neonatologists and pediatricians can affect that lung development by our decisions on the neonatal unit. And indeed, those abnormal lung functions in this prematurely born population are associated with adverse functional outcomes as well, which are important to our parents and indeed these young adults as they grow up. But also it highlights that even longer term follow-up than this 16 to 19-year-old cohort is needed. And if I just come back to that initial slide I showed where we saw the lung potential and then that slow decline into adulthood, if we assume that these prematurely born infants have slightly poorer lung function compared to their term-born peers, we don't understand how these lungs that are structurally different as well as functionally different, how these lungs change as they go through adulthood. And they may decline at a faster rate or even a slower rate, or they may decline at the same rate as what we have observed in the adult population. And this would be incredibly important to us to identify this trajectory, because it allows us to not only counsel our parents and our patients, but also to direct health resources, as certainly in the UK, the burden of COPD on our health system is significant. And as we are increasing survival and improving the number of babies that are discharged at lower and lower gestations, it's important to make sure that we're not creating an unmanageable burden in 40 years' time when these young patients might go on to develop COPD. I just end by thanking the funders of this study, which was the MRC and the NIHR, and also my supervisors, Professor Anne Greenoff and Janet Peacock and Dr. Alan Lunt. And indeed, certainly most of all, the young people of UCOS and their parents who have continued to engage with us. So thank you very much for listening to my talk.
Thank you, Dr. Christopher. It was an excellent presentation, great data that you have presented. We'd have some questions from the audience.
Hello?
Yeah.
Shall I tell factors actually? So we have, there are certain antenatal factors which cause intrauterine hypoxia. The most important factor is the function of the placenta and the lung are similar. Actually, so they are highly similar, hence the response to intrauterine environment usually it can damage the lung. Another important factor, there are certain antenatal factors like preeclampsia, chronic hypertension, thyroid heart disease, and then gestational diabetes, pre-gestational diabetes. So wherein we need to induce labor, preterm labor is indicated. So both preterm and growth restriction, there is a high chance of bronchopulmonary dysplasia. And superannuation, that extremely preterm fetus, maybe they deliver due to the chorioamnionitis or infections. That there is a high incidence of perinatal morbidity and mortality which lead to bronchopulmonary dysplasia. And then the postnatal factors, superannuation, so postnatal factors like high frequency oscillation, ventilation or mechanical, the ventilator support needed for the respiration, then even the prolonged patents of the ductus arteriosus, sepsis and inflammation also add to this problem. Recently, there is another view is that during preeclampsia, due to the placental ischemia, there is hypoxia occurs, and this SFLT, the placenta then produces anti-angiogenic factors and also reduced vasoendothelial growth factors. And this is SFLT1 is sufficient enough to cause lung damage in the intrauterine life itself. These are the points I would like to highlight. These are the points to introduce. All others are Dr. Christopher has hands up of you. It was a very informative speech. Thanks, Dr. Christopher Harris, and thanks, Dr. Astor team also to give me this opportunity to chair the session.
Who gave her comments? What is your comments on what she said?
I completely agree. I think that the factors that affect the lung development in utero and ex utero we are only scratching the surface as to what we know and understand, and I think it's highlighted by this the difficulties with planning these research studies. Anyone who's applied to a research grant knows how difficult it is to even achieve funding for shorter term studies of 1 or 2 years. And this is why many of the neonatal studies have looked at bronchopulmonary dysplasia or death, is because if you go to a research funder and ask them for the money to continue to follow patients up for 19 or 20 years, most research funders will say goodbye and no thank you very much. And so when as science has progressed and we've understood the effects of these things that my colleague has just mentioned, I think it is very clear to me that as time has progressed, we've found more and more factors that are important to fetal development. But we have to then collect that data in the neonatal period or in the antenatal period, and then look at those effects, not just in the neonatal outcomes, but also later on in life as well. This is a challenge for science. It's a challenge for us as neonatologists, and such an important challenge as well.
Well,
yeah. You want to ask?
Yeah.
Yes, Dr. Kitt. One point, and there are a lot of obstetricians also in this group. So one of the points I just want to revisit is basically you mentioned that the onset of labor, cesarean, and with a cesarean without onset of labor makes a lot of difference, isn't it? You said that it stimulates the immune system, yeah?
Yes. And I think it's important to point out that the immune system of premature babies is something that's being subject to more and more research as we go on. And we understand that when babies who are born prematurely are subjected to an inflammatory response, that in general, the response to that inflammatory stimuli is both delayed, and so they respond later. But then the ability of the premature infant to react accordingly to that and dampen down the inflammatory response is reduced. And so that the results of that inflammatory stimuli last for a lot longer than they would in a term-born infant. And this is probably why we have that honeymoon period in neonatology, where we have in those first 2 or 3 days, we see things getting better and better and better, because actually we're not seeing the results of that inflammatory stimuli for whatever we've done, even within our resuscitation and beyond. And then we see the inflammatory response kick in hugely at around day 2 or day 3. And then because of their poor responsiveness to to mediating interleukins such as interleukin 10, that inflammatory response lasts for days and days and days beyond, even when we've corrected what the cause of the inflammation is, the baby still goes on to have lots of inflammation. And whilst that's the general for preterm infants, what I think our data might allude to, although I completely accept it doesn't give an absolute, is that the onset of labor, which has been shown to prime the immune system, gives you a slightly better, if not perfect, response to inflammatory stimuli, and allows the body to react in a more appropriate way. And it might improve the longer term outcomes as time goes on.
Lovely, thank you very much.
Dr. Chris, when does the children you said follow up, their lung function reduces, when do they become symptomatic as far as wheezing is concerned? At what age do they become symptomatic? You're looking at exertion related wheeze or lung function. Are they symptomatic otherwise? And does this bronchial hyperactivity, do you think it's going to be permanent in these adolescents?
Yeah, I think that's a really good question, and another one that is frequently asked by the parents of our premature infants as well. Our data show that in childhood, certainly, our premature infants tend to wheeze more often and require more salbutamol and steroids. However, I think our respiratory colleagues would agree that seeing ex-premature babies in respiratory clinic with difficult to control wheeze is a thankless task, because very few of these prematurely born infants respond well to salbutamol and steroids compared to their term-born peers who present with wheeze. And Silas Katecha from Cardiff and his wife have done some amazing work looking at wheeze in this prematurely born population. And they have shown that whilst wheeze is very common, the wheezing very rarely responds to salbutamol. And indeed, the pathophysiology behind why the babies are wheezing, or why the young infants are wheezing, is very different to that of a reactive airways disease, like asthma, for example. And I think what we have seen in our population is that when these kids reach adulthood, very few of them have persistent wheeze. And in fact, very few of them have persistent symptoms. And I think that what the exercise data that we presented shows is that these young adults are actually living within their lung function. And so they often don't feel that they are particularly breathless or even go on to wheeze. But if you are at school and everyone is playing football and you can't keep up, then you tend to find something else to do other than play football or cricket with your friends. And this might lead to increased unhealthy activities, because certainly in United Kingdom schools, if you're not playing football, you're often smoking behind the bike sheds or something like that. And this might go on to highlight an even more at-risk population. Indeed, I think the Tasmanian study showed that the population study was that, with the exception of those with the absolute awful lung function associated with reactive airways disease, most 18-year-olds don't have symptoms, even though they have slightly poorer lung function. But their lung function at 18, even in the absence of symptoms at 18, led to symptoms when they were 45. And I think that that's an important factor to think about, is that at the moment there are loads of kids running around with poor lung function, and we won't know what symptoms they're going to have as much older adults until they reach that age. But we might be able to predict if we followed these kids up for longer and saw their lung function develop over time.
Manoj, any questions? Manoj?
Yes, Dr. Chris, it was an excellent talk, really thought-provoking. One, especially what you said about the evolution of the outcome in postnatal steroids. I just wanted to ask you regarding the UCOS trial. You know, there was another trial by Thompson et al. At the same time, initiated at the same time, which showed totally different outcomes, at least in the initial phase. Why do you think that UCOS trial, and because they were looking at the same population, same time, one was in US, one was in UK. That is the only difference I could find. Otherwise, almost everything is same, but the outcomes are totally different. Why do you think this happened?
Is that the steroid outcomes, Dr. Manoj?
It is a HFO, high frequency. Regarding the HFO, I just want to ask specifically regarding the HFO outcome.
Yeah, indeed. I think one of the difficulties with the UCOS trial was that we tried to get a population blend to reflect what was happening across the country, and that recognized the fact that oscillation was almost in its infancy at that stage. Not many people were oscillating, and the way that people were oscillating was very different between trusts and units and things like that. And so if you came to King's College, for example, the settings that we might use at King's and what made us happy to continue oscillating versus switching to conventional might have been slightly different to a centre in, say, Swansea in Wales, which oscillated slightly differently. And so we were looking at the effect of oscillation, if you like, on a population, rather than the specifics of how you oscillated and went on. And many people have suggested that if we repeated that trial today, where we know a lot more about oscillation and how to oscillate, and in fact, we're a lot more comfortable oscillating, then we might have different results in that factor. And the other thing is that, and coming back to the trial that you mentioned, another significant trial that was in the media at a similar time was the high the HiFi trial, which was the HiFi Lo-Fi trial, which looked at the high volume versus low volume strategies of oscillation. And it became apparent just as UCOS was starting that it was very important to oscillate on a high volume strategy rather than a low volume strategy. And UCOS incorporated that into their protocol so that nobody was oscillating on a low volume trial. And I think that the Thompson et al. Showed slightly different, had slightly different criteria for oscillating, but also I think the differences between the two trials shows the importance of examining a real world situation where if you have an intervention and you introduce it, you cannot rely on everyone to follow the protocols and the ways of doing it to the letter. And it may be that if we focused on a smaller number of units who had more experience oscillating, then we might have replicated the results of that other trial.
That's very good take. Actually, there is one more thing I would like to add to this, because you are comparing a mode that is done very well with a mode that is done very badly, because you have no volume targeted ventilation, so the conventional ventilation is perfect. Whereas on high frequency, you don't electively oscillate babies. You oscillate when they actually, and when you are desperate, and then you're trying to compare both. So you can't compare and then say that it probably, if you remove those things, oscillation stands. This is one concept that is coming up.
Absolutely. I think the UCOS was unique in that we randomized within 2 hours of birth. So as well as that rescue therapy that you mentioned, we were actually comparing the standards of using both of these modes of ventilation in a population who are relatively well. But there's a large number of infants who didn't tolerate oscillation. In fact, there was also a large number of infants who tried to conventionally ventilate and have to switch back as well. And so I think that it's very difficult to do a randomized trial in general on the neonatal unit, and certainly UCOS certainly had its challenges. And I agree with you that I think since the UCOS trial, we have more clearly understood that it is volume, not pressure, that's very important. And certainly now volume guarantee ventilation may have eliminated many of the needs for oscillation. But I think there's no getting away from the fact that on a volume targeted ventilation, we are using up to 7 mils per kilo. But on an oscillator, we can now limit that volume to 1 to 3 mils per kilo. And I'm very excited to see some of the trials currently underway comparing volume guarantee oscillation with conventional ventilation and seeing what the outcomes of those are. But I think it's fascinating, isn't it? The future of neonatology.
Very, very true. And regarding the other point I just mentioned about the steroids evolution, so what will be your take? Like postnatal steroids and the lung reaching its full potential in the adolescent period.
I think the steroid story is very difficult. It is very hard to get away from the data that shows that giving postnatal steroids reduces mortality in our population, because ultimately that has to be our most important outcome in neonatology is do we allow our patients to survive? But what I think the data highlights is that steroid use, that steroids are this very blunt instrument where we're trying to affect something very, very small and particular, which is the lungs' ability to get oxygen into the bloodstream. And to do that, we are using this drug, dexamethasone, which has this global effect on our premature neonates. Yeah. And I think it highlights that we need to both focus as scientists on why the dexamethasone is helping us to extubate these infants. And as clinicians, we need to be looking for more specific medication that will help us to achieve the same goals as steroids, but without the longer term side effects of our population. So I don't think I would suggest not using steroids, but certainly I would suggest that the scientific community needs to look at more detail as to why they work.
Okay, excellent talk. All the way.
Thank you very much, Dr. Manoj.
Thank you, Dr. Christopher. I must thank Dr. Anu for having introduced you to us. I don't know if she's here.
Yeah.
Anu, when I contacted her to get in touch with somebody in UK, she said, the first thing she said was contact Christopher. He is the man. And you came on board almost immediately. Please convey our regards to Anu too, when you see her, because we are so happy with the data that you presented, and it has been an excellent presentation. Thank you so much, and I hope your research work goes on. Your PhD is over? Your PhD is done?
PhD is over. I'm just waiting to defend.
Okay, very good. All the best.
All the best.
Thank you so much for inviting me to talk, and it's lovely to see colleagues past and present as well. It's wonderful to be a part of this. Thank you so much.
Thank you. Thank you so much.
Thank you. Take care.
Take care. Bye. I now invite Dr. Tina Annie Joy, the organizing secretary of this Monsoon CME 2020, to propose the vote of thanks.
As we come to the end of this Perinatology CME, I deem it a great honor to propose the vote of thanks to all those who have helped in making this webinar a resounding success. I wish to thank the inaugural team, Dr. Narayan M., IAP Kerala State President, Dr. Harish Pillai, Aster All India CEO, Dr. Pramod Warrior, Dr. Balachandar, Dr. Fessy Lewis, and Dr. Shirley Mathen for their presence today. I would like to express my profound gratitude to Dr. M.K.C. Nair for his wonderful oration. I would like to thank our distinguished speakers, Dr. Uma Ram, who took time out of a busy schedule on a Sunday to give us that enlightening talk. Dr. Christopher Harris, I thank you for joining us from London and enthralling us with your excellent talk. My sincere thanks to our esteemed moderators, Dr. Radhamani K., Dr. Jose Paul, Dr. Mayadevi Kurup, Dr. Shamima Anwar Sadat, Dr. V.C. Manoj, Dr. Rajshri S. for their inputs on the talks. I would like to thank Dr. Vishnu Mohan, Dr. P.M.C. Nair, and Dr. Zarina Khalid for conduct of the quiz and the free paper session. I thank Dr. Jason Unni and Dr. Jose Paul for chairing the oration, Dr. Shirley Mathen and Dr. Jason for their guidance, and the IT team of Aster IT department for the technical backup. I thank my organizing co-secretary, Dr. George Jose, for making my job a lot easier. I'm also grateful to our pharma sponsors. I would like to end by thanking our postgraduates, fellows for their participation, and all the delegate doctors who attended this webinar on this beautiful Sunday, thereby making it a grand success. Thank you all.
Shall we close? Thank you so much. Dr. Bodhankar, Dr. Tuteja, Dr. MKC, and Anu, thank you so much. Stop.